are not familiar with the Meet Google.
Stop sharing, it says.
Maybe stop sharing and just share the presentation once you put it back.
Okay, I tried to do that. Okay. And, well, I think Dr. Pizar gave me advice on how to do it. I'm not sure.
Lemlem, are you there?
There, just in the toolbar, there is an arrow that
Okay,
shows
so
up and it says present now.
yeah, I went back. So you, can you see now?
No,
Not yet.
After the hand sign, down to the toolbar, there is a...
Yeah, you know, I lost most.
On the toolbar.
It has back and forth. It has a slash. It has a show presenter view.
Yes.
Okay.
And click window.
Click. I did presenter view. And click window.
Yes.
So if you share to us, we can share the PowerPoint and then we can scroll it down.
Share with me, send it to you.
Yes, please.
Well, now
You have Lemlem Beza's email address. We can give you some time to just have Joanna just email it to me and Lemlem, so we can just have her do it.
So Joan, it's not working. Can you send the slideshow to that person? I'll send you the.
I think I have to email some
Yes, if you'd send that right now, that would be
All
good.
right.
Okay, thanks.
Bye-bye.
I know.
I just emailed also CCing Joanne, so when she
She's going to send it to you right now to
Okay.
Len.
okay, we'll do that. Outside, you're also CC'd on that email, so we can do that.
So while we're waiting for the slides, I guess I could talk a little bit about, but you don't see the words at all, so it's not going to work well. You know, I can describe one of the next slides, which is a big issue, and you can hear me?
Yes, we can hear you.
Yeah. You know, the next slide I was going to show, and I'll show them all shortly, would be that in 1965, really, there was an immense event that the National Academies of Science in the United States decided that there were 52 million accidental injuries that occurred, and 107,000 people were killed, and over 10 million were temporarily disabled, and 400,000 permanently impaired in America. So they decided that that was costing the United States billions of dollars. And the leaders of the country, the science, said this neglected epidemic of modern science is the nation's most important environmental health issue. And they really decided that people really had to change the way the world looked at the problems. That these were all causes of death that could be prevented. And it really showed that the public were not concerned about all these things, like the polio was there were no adequate vaccines getting out to the community. There were injuries of all sorts that they felt could be prevented. Car crashes, things of that nature that really had to be addressed in a different fashion. And this ever-increasing number of accidents led to a belief that the field of emergency healthcare had to be developed. There had to be paramedics, there had to be people trained, there had to be good ambulance systems, there had to be organizations that were really going to deal with the big issues in our society. And that many things were established following this 1965 study. And it led to what was called the development of emergency care. And it said we have to develop great systems for critical care, for intensive care units, for poison services, for neonatal care, for trauma care, and went through all of the types of people who were suffering through critical emergencies. And it began to create the kind of education that was necessary, and emergency medicine training began at that time. And also the development of poison centers was recognized. And experts from nursing and administration and physician offices all got together to collaborate on looking at how we would change the way healthcare was going to be delivered. So it really started from a governmental recognition that all these things that happened, this accidental death and disabilities that were neglected by modern society. They talked about this being an accident. But what I'm going to show is that really these weren't accidents. These were totally preventable events that by better science and better collaboration among people who looked at these injuries, things could be changed. So what we really began to do is to work as a team of young people in the United States to get in every city to begin to work collaboratively on every single person, for example, who was poisoned. And we got people who were working in various departments across the country, and we said, how should we improve the care of people with these particular poisonings? And so we thought about a number of them. And the example was that when I was a young man, we saw people come in who had taken strong concentrations of sodium hydroxide or sulfuric acid or hydrochloric acid. And those individuals were children typically. Something was lying around the house and it was a bottle. And there was no such thing as a baby-proof cap at that point. There was no such thing as a warning about this being dangerous. And people drank something down. Children got into those things because parents put things under the sink. They didn't put it, or they left it out on a shelf where a child could reach it. It was naturally exploring. And so the process had to change. And that's what people in pediatrics, and internal medicine, and emergency medicine, and just general citizens started to work together to make the critical changes. Has Joan sent you the slides?
Not yet. I'm just refreshing. No, not yet. If you have Dr. Kovan, I don't know if you have my number. You can text me her number and I can call her and talk to her as you just.
I just spoke with her. But she had the
Maybe she sent it to Lemlem.
she sent it to Lemlem. Is that?
Yeah. So
Let me
maybe.
check.
No, I'm checking. No, it's not yet sent.
We can wait a few minutes and then.
Maybe it wasn't advancing because it was under edit format. If you click on the slide up top, it says edit on your slide. Enable editing or something.
Show task display settings. Duplicate slideshow, swap presenter view and slideshows here.
On the PowerPoint itself, there is a yellow bar on top.
I don't see it on that. I see there's an end slideshow. There's a yellow, there's a bar. Yeah.
Yeah, does it say like edit something, edit the slides?
Toy slides. There's one that says display settings and it says show taskbar. Okay, let's see taskbar. Doesn't
I don't
know.
know about it. Yeah.
So I went back now to the, I can try to share. So
Yeah, share the
slideshow and the share we did. That's going to look like.
It's like the screen with the arrow up.
Screen with the arrow up. Yeah.
It's right next to the raised hand, I believe.
I don't, those things aren't up anymore.
Oh. Are you able to go back out in the email and then maybe reconnect? Because I think the thing with the Google link is different.
Slideshow setup. So set up slideshow, show type presented by speaker, full screen, browse by individual, loop. So it's full speaker screen. Slideshow sorter.
Do you see the arrow that says present now? That was CC, small. Next to the CC is a hand sign, and then next to it is an arrow.
Yeah, that disappeared from my screen. I don't see that.
Maybe you have to go find. You can go back to the email and rejoin again. That might come up again. I'm not too savvy with Google link. Also,
I wasn't any savvy. I had no savvy here, so I can.
If you log out and then re-log in, so that way it may pop up everything.
Okay, let me do log out. Okay, so
just leave the meet. Oh yeah, I have to log completely out.
Log completely out. But I have it on my. Okay, so I have you on here. So now the question is, which bar? Turn on captions. Right. Type.
oh, that's the one. The hand raised. You see, present now. Next arrow.
Yeah, and I'll go in that, and now go to your entire screen.
No, you go to the window. The window.
Okay. So I probably don't. Now I don't see my talk at all because
So the other way is since there is time constraints to it, so that can we make it verbally without having if this challenge?
Yeah.
No, I get the slide now. I can share.
Okay, great.
I get the
Okay,
slide.
very
Go
good.
ahead.
Yeah. I'm downloading. Please wait me.
okay. That they got it, June. Thanks. Starting up again. Okay, so that's the idea of the beginning of the effort. All of us can work together in doing something special. Oh, I saw the slide. It's gone.
Yeah. Salsite, is there an issue with it? Lamna, can you hear me?
Yeah, so it's back.
I'm sharing it again. Okay.
Okay. So obviously I can't advance it, right? You will have to.
Yeah.
So let's go to
You can
go
just
to- go to
I think
next slide. I've talked about these issues of principle and organization. So let's go to the next slide. I don't see the next slide. I don't know whether you do. So can you advance to the next slide? Good. This is what I've just talked about the National Academy of Sciences. Next slide, please. So here was an example of the things that you could see. You could see Drano, which is lethal sodium hydroxide concentrations, readily available, no baby proofing of a cap. And this led to esophageal strictures, as you can see in this radiograph, a barium swallow many years ago. Next slide, please. And on the next slide, it says, why don't we see these things again any longer? Why don't I see them today? Next slide, please. And the next slide really shows in 1950, the American Academy of Pediatrics created a committee for accident prevention. And the first poison centers were developed in the 1950s in America, ours in New York in 1955. And one of the things that people said, we had to set the maximal concentrations for this particular toxin. And we had to child-proof everything that was a risk to a child. It could be pills, it could be liquids of sorts, and that there was a Poison Prevention Packaging Act that set a standard for the country about how any poison, anything with a potential poisoning had to be controlled. Then you created a Consumer Product Safety Commission that really set the standards of what a product could be. These Tide Pods for dishwashers or for soaps weren't necessary. They developed them recently. Consumer Product Safety Commission should have prevented that. A bottle that doesn't say exactly the right thing on the label shouldn't be released. Products shouldn't be developed that are risks to children. There had to be on every bottle that had the content was a high risk. There had to be a cap and closure standard. There had to be warning signals that might scare a child away. They don't work very well. These are after the fact for something that's toxic. I mentioned earlier that things were kept under the sink. People kept valuable things of their home high up so the kids don't get to it, but the other things that are quite poisonous are left down below. And there weren't childproof locks as yet developed. So there were many things to do. Each of them was a way to respond to a toxin. Next slide, please. So here was an example of chiclets, you know, the gum that people eat. And here was an Asper gum that looked exactly the same way. You couldn't differentiate it. A child would see that and take a lot. And in that era, we saw many overdoses of children by Asper gum. So just the advertising was bad. It was not thoughtful on the part of the pharmaceutical industry. Next slide, please. This happened 50 years ago. We eliminated that. The next slide would be, here you're selling Pepsi-Cola, and here's a radiator sealer that's a dangerous product, looks exactly like the Pepsi-Cola can. The inexcusable effort that the pharmaceutical industry wasn't involved in this time. This was someone trying to advertise and sell more of this sealer, but that every child is going to be confused in the world on this particular issue. Next slide. So this was an example of the hydrocarbon pneumonitis that I would see. And what you really saw was that hydrocarbon pneumonitis was occurred because there were many bottles that had lemon polish, for example, and they smelled like lemons, but the advertisement looked quite interesting to the child. It attracted the adults also, and one wasn't then careful about this lemon spray, and we had kids who were then inhaling or ingesting this particular toxin. So warning labels had to be established, and a bottle had to be, not only the product, but the bottle it was in had to be looked at. Next slide, please. And so here's a project that a number of us worked on in Ghana, really looking at the problem of kerosene poisoning, which was so common in Ghana. It had been very common in the United States, and these are older articles from the 1980s, kerosene poisoning in the United States, where the kerosene was eliminated as a fuel because, and for use around the house, because so commonly it was ingested, and so commonly it led to catastrophic injury for kids. And you can see a couple of these older articles, one from Southern Rhodesia or Zimbabwe, one from Barbados, and then a major effort in our country. And this, our team of people in emergency medicine and public health, and all of the district health officers in Ghana went everywhere across the country to the district health offices and discussed the idea of how bad the risk of kerosene poisoning was. And particularly, if you see on the graphic, I don't know what, in the United States, people used to use in the 60s and 70s and 80s, 1960s, 70s, and 80s, people used Ipecac, syrup of Ipecac, to make a child vomit, to get the toxin out. We stopped doing that, particularly for hydrocarbons, because we recognized that if the child were given that syrup of Ipecac, the child aspirated. And one of the first days I got to work in Accra, when I was working with our team there, a child came into the emergency department. The child had, while the mother was out, father was out, the babysitter saw the young child drink some of the kerosene, and the child was well when the parents got home. The parents were worried. They did what was typical in Ghana at that time. They went to get some palm oil, and they gave the palm oil to the child to vomit. The child vomited, and then the child became critically ill and aspirated extensively the kerosene that was in the intestine, in the stomach, and ended up dying in the emergency department. So we then used that as an example to try to help. And these were so that's the way we went house by house or community by community in collaboration with the district health officers of Ghana. Next slide, please. Next slide, if you can. So here are lead lines, critical problem in our world, and maybe in your world as well, certainly as well in Ghana. Next slide, please. Next slide. So here was an example. At the same time that people were developing lead poisoning, we were recognizing that the houses were covered with leaded paint. Here was an advertisement by the American lead industry, the people who produce lead. Lead helps to guard your health, and it gives many reasons. It brings in pipes, it brings good, clean water to your house. It's used in paints, it makes solid paints. But obviously, America is suffering the lead that was left down by those pipes to this day in schools and industry and in the paints and in the children then eating that. Next slide. So there's a big disconnect and there's a big advertisement to say that all oil is good. Here was a good example for us. Everyone had neglected this type of person in emergency departments. They said, well, we'll look at all his structural injuries from the crash, but we didn't look to understand why there was a crash. And so one began, next slide, began to think about alcoholism and how trauma had to be affected. We then looked at the really a statement that was said by Schopenhauer, a thinker in Germany in the 1800s and 1900s, the 1800s. The task is not so much to see what no one has seen, but to think what no one has yet thought about, that which everyone sees. So the homeless person was very important for us to think about improving the care in America. The people who were impoverished, what were their risks? What were the social factors that brought them to the emergency department? What were the things that were injuring these individuals? Next slide. So this is 30 years ago, 35 years ago maybe, when Edward Bernstein from the Boston City Hospital, Arthur Kellerman from the Grady Hospital in Atlanta, and I were leaders on the Society for Academic Emergency Medicine. And we said that public health approach to emergency medicine was essential for the 21st century. We really had to change the way we did our work. And we had to say that our public health system was inadequate in America to provide the resources, the incentives, and the organizational changes that promote integration of public health and preventive services into the practice of emergency medicine. And we began to change what we thought emergency medicine had to do. And that was truly to prevent events. Next slide. So the big difference was that I think at that time when I began to study, everybody said, well, on the left side is this curative effort. We want to identify the pathology. We want to restore the person's health. We want to promote the individual good for a single person. And we went to, those are going to be clinical issues. On the other hand, the themes that we were pushing and others were really identify the risk that brought the person to the emergency department, identify the risk that's associated with the poisoning, reduce that risk, shift the normal thing. If you don't have bottles that the child can drink, the child's not going to get poisoned that way. If you don't have containers with toxic substances readily available, you'll change the process. That it was a responsibility is to a population, and that there are many things happening, even if you don't have it in your the injury that you see, it's happening everywhere else. And that behavioral and social interventions are prominent. And they must be accompanied by clinical intervention. Sure, every time I see someone in the emergency department, next slide, please. Every time I see someone in the emergency department, I want to do better for that person. But I also want to think about how I've done wrong and how society has done wrong. This is the way people used to be restrained. Leather, ties around the arms, or a straight jacket. And those people died because we weren't doing all the things that had to be done. Next slide. Next slide, please. So here's an example. This is actually Bob Hoffman, who you'll see later this afternoon, I guess. And this is the devices that we thought restraining could be used. We don't want vinyl bags. We wanted vests that might be open and allow for air or water to be placed on someone who is extremely hyperthermic under these circumstances. We thought a lot about that when we saw patients taking drug overdoses that led them to be very agitated, or people who were alcoholics who became agitated and very febrile. Next slide, please. Next slide. So we created a poison center system, New York, we have many people who answer the phones. They're answering phones all day long. They get 100,000 calls in a year, more or less that. They're pharmacists and nurses that answer those calls. They're trained by us and in every center in the country. They have to pass a national examination, and they have to have ongoing education. Next slide. But nurses and pharmacists do that. They do that with great skill and great enthusiasm. The physician staff in our poison center would be a number of medical toxicologists. We said 2.5 are paid by the city or the state. They're clinical toxicologists who are pharmacists, PharmDs, who've done their doctorate in pharmacy, and they're then 6 toxicology fellows who are trained either in emergency medicine or pediatrics or occupational medicine. They have 2 years of supervised training, and they spend time full-time in our poison center in public hospitals. So the education of the program director, the public education, is really an advanced degree in education. And there are a lot of community educators because we think and we focus, for example, on people who speak Spanish or Latino or Latinx or Chinese, big communities for example, in New York, where the people aren't getting the same education and need intense education in their particular language. And it's important to know the individual culture of any particular community, is how to go and work with them and how to listen effectively and be able to change the practice for the individuals. Next slide. The critical part of the payment is that public education. So we took the state of New York. In America, you probably start with an advantage than we had. In America, when we started our efforts, there were 680 places in the United States that said they were poison services. Some of them had it in the back of the emergency department. There was a telephone there, and there was a book, what to look up and say. Whereas we are now, in the state of New York, there were 8 in 1980 poison centers. Now there are 2 poison centers, one for the top 10 million in the state in the north, and one for the poison centers in the southern part of the state, another 10 million. But we felt that if you centralize these centers, you could get the kind of education and support that the people would need. You had enough cases so that everyone could discuss the cases and work. You can go to the next slide. And so they're 24-hour a day, 7 days a week, telephone services. There has to be, the public can call at any time, any health professional can call. We provide consultation at the local hospitals. We have an outpatient clinic, and we have a translation line that handles 150 different languages because everyone in the world's language is used in our city. Next slide, please. This was in 2015. It's about the same now, about 100,000 calls. 66,000 are human exposures. 26,000 are information requests. They're mostly children. You know, someone who's a substance user probably doesn't call the poison center. The family might do that. They might call the emergency medical services. 39% of the calls are under the age of 5. These are unintentional ingestions. They didn't mean to do it. The question is, somebody inadvertently left something about. It's not an accident because it could have been prevented. We use your word unintentional. And very commonly, it's cosmetic or personal household products. Most of the exposures, most of the times that people call, it's not going to be an adverse outcome. And next slide. And our job really is to help people. We don't want people to rush to the hospital if it does not necessary. We want people to talk over the top effectively with people to make sure we can get them the kind of care they need. So we get $3 million from the state of New York, the city of New York, and federal government. It costs $30 per call. Next slide. That's how much we spend in principle on every call. No patient pays anything. No doctor pays anything. It's part of the taxes of the government. Next slide, please. And what we show periodically, every several years, is that what do we save? We save 40,000 people who didn't have to be hospitalized. They didn't have to go to they didn't have to go to an emergency department. That saves $500 per ambulance visit in the United States. The 10,000 people who don't have to go by ambulance, that's already $5 million we saved. The emergency department visit would cost a lot of money. We take the 40,000 hospital visits and multiply that by 350, that's 14 million. So total savings are tremendous. That's just in prevention. And other poison centers across the country have done the same thing. To show really what you do, you stop the parent from work. You can go to the next slide. You stop the parent from worrying. You improve the care for those who really need it. You focus on the really sick. You don't, sometimes when someone says they were exposed to a product that's very bad, but when you talk and find out that none of the symptoms you expect with that, then we say they don't have to come right now, but they should get organized and continue to call us, and we'll decide if they have to come to the hospital. But it decreases the number of tests, it decreases the stress on the families, it decreases the waiting time for ambulances to do other things. Next slide. So there are reports from several parts of the country, and that the potential impact of poison centers on rural hospitals, rates for poisoning, the impact of poison control centers on the length of hospital stay. When the toxicologist is involved helping, they help decide what's the antidote that's necessary, how long should someone stay. When they're using a poison center, they're really just helping people decide, well, is it serious enough? They said they took something bad. Usually they say it took a little red berry on the plant next door. Well, if you got a picture of that berry or a picture of that leaf, for us it makes a big difference and we can decide whether it's safe or not. Next slide, please. So the Poison Center is a bonded effort between, on the right, the university, on the left, the health department, helping to support the Poison Center, and obviously working with the Mayor's Office of Emergency Management, because we're worried always about terrorism, or we're worried about supplies in the water supply or the food that's dangerous, something can happen. So there's a very coordinated effort in the systems of the government. Next slide. So here are the types of communications, lots of telephonic communications, moving from EMS, taking someone directly from the field, talking over the phone, to the Poison Center and the emergency department at the same time, really integrating EMS, the emergency department, and the health department, as well as the Poison Center. Next slide. Next slide, please.
Sarsa, next slide.
There was a question from someone.
I think Sarsa, are you there? There are several questions, Dr. Goldfang. I don't know if we want to address them as we go, or.
Sure, I'd be happy to do that. I'd take the next slide too. I don't know.
Yeah, Sarsa.
What was the question about?
So there are several questions on one is anything you can say on the prognosis of street children who sniff glue, kerosene, and hydrocarbons. It's common in developing countries that are the reason being behind they don't feel cold in the rainy season if they sniff hydrocarbons. So they use it to keep warm, especially for people that are in the streets and homeless children. We see that a lot. So that was the question.
Sure. I mean, clearly there are things that you have to make solutions for. The hydrocarbon it's a risk, great consequence, and you try to limit in every fashion you can. I mean, clearly it's not something that you can eliminate until you have the economic support for whomever is doing this. But one gets in trouble by some people get significant cardiac abnormalities associated with it. Well, this is just says where we are. We can do the next slide thereafter. It says I think we've talked most about this. Go to the next slide, please.
Finnegan, next slide. I think the slide advancement is an issue because of the internet connection.
Yeah.
Sunny, this is okay.
This is the budget. We've done that. We've done the deficit. We did that. Next slide. We did that. Also we did that. Next one. Okay, so here's that center. You know, it's really an educational site of great importance. There's a poison center specialist in the top, works with the doctors in pharmacy, works with the toxicology fellows, and then a host of subspecialties: botany, entomology, environmental medicine, herpetology, mycology, occupational health, and radiation medicine, and links with laboratories and medical examiners. It's okay. You can go to the next. Other regional centers. So here is just an example we did for a public service announcement many years ago. And, you know, the little child up there and can touch all of these toxins, and thinking about how you separate the child from the toxin. And it's very difficult, and it depends upon the finances, and it depends upon the packaging in the country, but it's important to think about that as every example. And we use that. Next slide, please. We use really that to enhance education and awareness and prevention. And we use it. Every trainee in emergency medicine in the city of New York spends a month at the New York City Poison Center, you know, where they get weekly journal clubs, where they have a consultants conference, where they do an annual review course. And they go to our outpatient toxicology clinic. They do patient consultations in 3 hospitals and patient care, bedside care in the emergency department in the ICU. So this is what this National Academy of Sciences studied. The long-term solution to the injury problem is prevention. The major responsibility for accident prevention rests not with the medical profession, but with educators, industrialists, engineers, public health officials, regulatory officials, and private citizens. And this is a graphic. You know, accidents are not random events. They are predictable. They can be prevented. And I think that's what gives us a lot of power as doctors. And that's good. Next slide is fine, please. Next slide. And here is this fellow, Bill Haddon. His job came out of, he's a doctor, surgeon, or internist who really looked at, he's headed the National Highway Traffic Safety Administration in America. And he said, let's look at every single car crash. Let's look what happened to the driver before the event, in the pre-event, what happened during the event, what happened in the post-event, and the end result. And looking at that, the human cost, the car, and speeding. So what he did is he said, you know, let's get driver's education in the beginning. Let's build cars that are safer, crumple zones. Let's make guardrails and divided highways. So he wanted to address everything in society. The human being, the vehicle, let's say, this energy, the uncontrolled energy, this car, and what happens outside. And then when you got to the event, let's use seat belts. Let's activate anti-lock brakes and deployment of airbags. Let's witness contact in emergency medical services, because when he started in the 1960s, there wasn't good emergency medical services. But he built this type of strategy. Post-event, we want first aid. We want to use emergency equipment to rescue victims. We want to use emergency care and rehabilitation to care in the post-event. We think about the injured passenger, the damaged car, and the damage to property. So thinking about whether it's the kerosene in the community or it's a lead in the water, these are the things that you want to look at in a systematic fashion. And we use this as a basic approach to research with regard to public health. Next slide. And here you can compare the vehicular crash, which alcohol and drug avoidance, we prevent a lot of vehicular crashes. But we decided that, you know, seatbelts are great, but they're only great if people put them on. It's the way vaccinations are great for COVID, but if people don't take them, it doesn't help. So that's why he developed the idea of airbags, that every car had to be made with an airbag, because no matter what the person thought about putting on the seatbelt, you were going to be protected. And then you go to detoxification centers and trained citizen first aid to help. But here in poison ingestion said, make child-proof containers, he would say. Make aversive agents, caustics, put signs there, put smells on it, make the taste unbearable if someone tasted even a drop, and change the concentrations. And then the idea in the post-event work would be this poison center medical toxicologist approach. Next slide. So the quality assurance we have for all the calls we get, we're really to have the physician involved daily to go over all the cases that occurred in the poison center. All hospital calls were reviewed daily. This home calls were reviewed. You can go on to the next slide. We worked on building textbooks and things like that. We reviewed articles. We did original research. We did case reports. Next slide. Note editorials. This is, on the far left is the first edition of our textbook. And that was when I worked by myself in the South Bronx of New York. And the textbooks got bigger and more substantial as the number of people we had. It used to be written by 2 or 4 of us, and then it was written by 6 of us. And now we have 150 or 200 people who are involved in this 11th edition. And it's really people from across the country, across the world, looking at their perspectives in poisoning. People from Africa, Asia, South America, the United States, everywhere. And so that to get some themes, and we really review this every 4 years and work as a team to improve better standards for our country. Next slide. Sometimes we develop pins that said 212 poisons to make it easy for people to know to call. Next slide. Here's the universal number for the United States that you can call from anywhere. Here's a slide. Okay, that's a number, that's an approach. And this is a big deal to think about this. This is the current head of the National Highway Traffic Safety Administration in 1995. He said, on the right-hand side of this graphic is where the severe and fatal and critically ill, and the severity of injuries on the horizontal line. And almost all of our injury goes to the very right-hand side of this graphic. Whereas what Haddon wanted us to do, and what we have to do to make society better, is to work on the left-hand side of the graphic. The people who have minor and moderate injuries, how did it happen to them? What should be done? How can you prevent it? Next slide. In medical toxicology, the mission is to evaluating, managing, treating, and preventing unexpected illness and injury. And how to expand that, how to work wherever you are to have people think about what we could have done to prevent it. And how do you create the kind of faculty interested in that? And ultimately, how do you plan the scientists for the future? So I think that the other points, I guess we can skip. We can do the questions, I think. Everybody wants to think of something to do. Fields of knowledge are poorly studied in toxicology across the world. And how we do better at those things becomes terribly important. How do you create the curriculums? How do you train people? How do you focus on learning? And how do we all cooperate? And how do you have enough people to think through the problems as a team? All become really the critical issues. So I'm happy to take, if you have there are other questions, Sion, we should do?
Yes, there's some questions, and I think we'll take questions from the audience if there are people who want to ask you directly. But thank you, Dr. Goldfang. This was very, very helpful. And of course, as you were talking, I was really thinking about what is happening currently in Ethiopia and what you described 30, 40 years ago in the New York setting. There are things that are very similar to what's happening in Ethiopia. So thank you for sharing all that experience, and I'm pretty sure people learned a lot. So I think you addressed the question of the kerosene and hydrocarbons. The next question is, are the poisoning control centers, do they take patients or give information to hospitals and to the community only, or do they do both? I think you've already mentioned that, but maybe just clarifying that, and also maybe discussing things that you've seen in other countries might help too.
Okay. So we believe that anyone in the city can call. The problem we have is that there's so many different languages, and I think people who speak different languages are discouraged from doing it. You need people who can listen to the call. So we have people who are nurses and pharmacists, and that's their sole job, is to listen to the call and collect the information and talk to the family, and maybe get photos together, whatever the family wants to send. They communicate a lot, and then they talk with the next level of person, the fellow, someone who's already finished training in, let's say, emergency medicine or pediatrics or internal medicine. That person then goes and collects more information, talks to the family. They make decisions about whether the person should be sent by ambulance or whether the person can stay where they are and to help them be cared right under the circumstances they have. So that we want everybody to have the right to call. It's free in the process. Some patients the physicians and the pharmacists will send the ambulance immediately. Sometimes, as I said, the ambulance driver is talking at the same time as the patient is because they're moving the person because they already decided to take the person to the hospital. But that kind of communication, the Poison Center itself doesn't care for patients. The Poison Center exists independent as a health department. It's meant as a public health agency, whereas the people in the hospital are going to be talking directly to the Poison Center because for most hospitals, the most important experts are really at the Poison Center. But we, as a member of the Poison Center staff, we have the right to go to any hospital in the city of New York because any poisoning might be a public health concern. And so that we work very closely with hospitals and we talk to the physicians there and we go to assist if they wish. In some rare cases, immediately someone that sounds serious, it could be, if it's a case of botulism, they're going to get a lot of people from the state health department and probably the Centers for Disease Control. So the different types of people are integrated. Everybody, there are only 48 poison centers in the United States. There's one in every state, more or less that. Some are joined. And they try to aggregate people carefully because there's so few toxicologists and there's so many poisonings and you need to do it. We need to see enough cases to become good at and to feel that we're responsible.
Thank you, Dr. Goldfrank. Well, December or Lemlem, if there are any direct questions or anything, this is what I see in the what's typed. Anything else? If anyone has any questions, they can ask directly.
So we will limit number of questions. They are invited to drop the question on the chat box, and we will let few of the participants to involve in direct questioning. And we invite the next discussion leader is Dr. Sofia, who will have 10 minutes. 5 minutes will be sharing the national Ethiopian experience and asking about the USA experience in detail. So I hope Dr. Sofia is around. So she is the first batch of emergency physician and assistant professor. She is researcher and academic staff in Black Lion Hospital at Addis Ababa University. So she's my teacher. I'm honored to introduce her to have a brief discussion on national establishment experience and forwarding questions to Professor. So Dr. Sofia, I hope you are around.
Thank you, Aldasan, but yes, I'm around. So I'm not really prepared to give a lot of, I'm not prepared to give some slides or a lot of discussion about the experience of the Poison Center that we had working here in St. Peter's Specialized Hospital. But I can say a few things, and if there are questions that needs to be addressed, I'm willing to do so. First of all, can you hear me?
Yes, of course.
Thank you. So as most of you guys who practice here know that the first poison control center was established at St. Peter's Specialized Hospital a few years ago. Sadly, the center is closed now due to COVID because the whole hospital was converted into a COVID center, and there was not time to move all the resources and the staff to another setup. The idea of the poison control center that we had here is very different from what we were listening from our doctors and professors in the States. So the hospital had a separate area with 2 ICU beds and 4 step-down or recovery beds to accept patients who we deemed to be toxicology patients or patients who had poisoning. And then there was also an idea to establish a call center from that setup. And the call center was supposed to give service to the community as well as to hospitals, so that physicians and health professionals can access the center's resources to treat patients in their setup. So there were, with all these problems, we tried to see a lot of patients that were referred from different hospitals. We also tried to give some advice, but the phone lines never worked full time, and there was a lot of problem with that. But I think the center had seen a lot of sophisticated cases that needed ICU from different poisonings. And the common poisonings in our setup, as you know, are pesticides, corrosives, and some pharmaceuticals like barbiturates and paracetamol. There were a lot of challenges. I mean, when the center was established, for one, there's no trained medical toxicologist in our country. There were a lot of problems with drugs and antidotes. And the idea of referring emergency patients, poisoned patients from another setup to one hospital at St. Peter's was very difficult. By the time the patients arrive, it's too late to decontaminate. Maybe it's too late to give the antidote, whatever, if the antidote is available, and a lot of other problems too. So if there are any questions I can address, I will. And if any one of you need a detailed description of the work that the center did, I can forward some slides. I'm not prepared now, but I can forward some slides via email if you want to discuss more or if you want to know more.
Thank you so much, Dr. Sofia, for your brief sharing of experience in establishment of treatment center. Really, it's a historical event that you involved in establishment in a national treatment toxicology center. I hope it will come to existence.
Yeah, hopefully.
Yeah, and then I hope our colleagues from USA, I think they will say something about this center and how they struggled when they established their own center. So, Dr. Tion, back to you.
Okay, thank you, Sophia, Dr. Sophia, for the perspectives that was given on the establishment. I just want to ask everyone to mute their mic until they speak, or Salsa, if you could please mute them as they speak. Dr. Gofang and Dr. Sophia, I just want to also mention that they were together as part of the Ministries of Health poison control guideline that was developed a few years ago. And this great collaboration between the US institution and Ethiopian institution. So we heard a little bit from Dr. Sophia. Dr. Gofang, I don't know if you have anything to reflect on that, what some of the challenge that she mentioned with the establishment, unfortunately now closed due to COVID because the hospital and the area had to be repurposed. And then there are two questions afterward, then I'll ask you those questions and then we might conclude this session.
Okay, so I think that everyone has problems when poison centers are developed. And the crises of COVID are consequential, but in our country, we had lots of calls about too much hydroxychloroquine or too much bleach or too much ivermectin, silly stuff that never should have been done, or people, wanting to inject things, or ozone. I mean, we had such strange things that are irrational. And so the Poison Center was very busy in trying to help educate people. People would call. If they hear someone say something about using hydroxychloroquine or an animal medication, and they want to use that, or they can't afford it and they take something else. So it has terrible things that happen. Poison centers are vital, particularly in epidemics or pandemics. So I think that we don't mix the clinical care with actually the poisoning and management of calls, and so that component obviously would be vital to maintain in some fashion, because there would be things to do even if the poisoned cases are cared for in a different spot, because I think it's the wisdom that you develop as leaders about how to help the people deal with the things that are unknown. And I think it's the adaptability of the Poison Center is very important. I mean, how you do it is something local. Many poison centers across the country are distinctly different. Many poison centers, over the years, it used to be 650. Now they're down to 48 or so because they closed, because they couldn't do all the things. But if all the support you had from the government, it'd be nice if you did some of the things that you did in the past, because I'm sure the problems are greater. We saw more drug abuse. We saw more kids getting into things because there were all sorts of medications around. We had all sorts of difficulties about alternative therapies people tried. So I don't think, a pandemic is a time for less poison center. It's time for more poison center, but maybe a different role. I think because you are very important, and it would be nice to maintain that strategy if you could, because poisonings don't go away if you don't register the numbers. It's just you don't recognize what's happening. And I think all of you helping with courage to the local team, would make it work again. You'd expect something different, but the kind of assistance that the Poison Center could develop could be very interesting and very important.
Thank you, Dr. Goldfrank. So I think I saw one person who raised their hand. Until that person who raised their hand are allowed, I guess, by the facilitators, I'm going to ask one question. I think, so somebody said, thank you very much for the presentation. I see that in toxicology roadmap, the intervention is mainly focused on the social emergency medicine component. The upstream factors of healthcare are the most important from what we see in the presentation. How did you start it all? Was it an individual initiative or was it organized movement by association? I think you mentioned most of the things, but maybe to reiterate for some of the people who might have joined late, Dr. Goldfrank.
Yeah, well, you all have to look at what makes you an emergency physician. But when I started, every single person I looked at who had a poisoning or had a vehicular crash or fell down the stairs or fell out of a window, it was always a problem that could have been prevented. Someone left a gun around, someone left a poison around, someone left a car, driving in a car when drunk. I mean, I think that there's so many things that we do today that are cause us harm. The people who have masks and don't wear the masks in the face of someone with disease, they don't believe in the mask, or they don't believe in getting a vaccination. Those are unintentional injuries. They're done by people who weren't thinking about the risks associated with it. So I think that's that paper that I suggested. We really, I think, changed emergency medicine so that they're really the social determinants for each individual lead that person to get into some problem. It may be poverty. It may be not enough intellectual skills, not enough education. Just daring and doing things that are high risk. Those all are the things that we really work on, because there are more than enough patients that we could care for if we did better social action and better education that wouldn't have to come to hospitals or emergency departments. So that's our strong belief, that we really can prevent masses of injuries by doing good conscientious assessment of the social factors that lead these people to do the things that they do.
Dr. Goldfrank, so I think one more question from Dr. Getao Hassan. I see that Sophia is answering the questions in regards to the poison control centers in Ethiopia. So for the sake of time, I would let Sophia answer those in the chat. If there are any other questions, please type in the chat. I don't think we have time to have a raised discussion directly, but get out one question, and then we'll end the discussion with Dr. Goldfrank.
Thank you. This is Gaetao. Thank you very much, Dr. Goldfrank, for the insightful and important lecture for Ethiopia at this point. I was there recently, came back about a week ago, and I've had a discussion with the society board members, and there is an increasing in toxic ingestion, as you said, preventable or accidental. And some of them are pesticides, herbicides, they're being used, but half of them are unknown what it is. It's just a powder or a pill.
Yeah.
Even if they take it, it's hard to know what it is, and it's hard to address these issues. And we have a recent discussion with the CDC to see, what can be done. We don't even know where they come from, this, powders or pills. They take them, the toxidrome is different. There's a very challenging time for them. As you said, it's first awareness, recognition, and advocacy. So it's stuck at the, I think, recognition phase now.
Yeah.
What can be done, to tackle these things?
Most of us, many of the herbicides, for example, the worst herbicide probably that exists is paraquat. I don't know if you have that in Ethiopia, but we don't let people use that in the United States any longer. It's too dangerous. In many countries, such as Sri Lanka or parts of India, it's been banned because it's untreatable as a poison. And the herbicide is so dangerous to people, particularly farmers who are depressed because of the climate is worse or because the crops are bad that year. And then that pesticide is there, it's not protected. People take a swallow is enough to kill most people. So we would say that should be banned on an international basis. And I've spoken, for example, in a number of African countries as well as in Asia, where it was banned in Korea, it's banned in Taiwan, because it's too dangerous. And that many of the toxicologists would say that the level 1 and level 2 organic phosphorus compounds are too dangerous to be used. You don't need that. The level 3 pesticides probably aren't necessary, but for sure they're too great a risk, and you can get by with eliminating all of those 1 and 2. And we've got those listed in our textbook, and Michael Edelson, who writes the chapter in our textbook, has taken a goal across, he's worked essentially in Sri Lanka, but also in some African countries, to really look at the idea that these pesticides are far too dangerous to have available. And if they were banned, it would not hurt crop production and it would save lives. His goal, there are 10,000 to 20,000 people who are on ventilators in the world right now, who are there because of pesticides, and they don't have to have that done. People can't afford the antidotes, they can't afford the intubation and the care. The objective really would be to prevent that from happening. There is no adequate treatment when people take a lot of this in the developing world. There aren't enough resources. And certainly now during COVID, I'm sure that people are dying who just do this. So it's totally preventable. And it destroys the people who were depressed, they're not enough psychiatrists to help them before that, and the poison is readily available. It's not protected. We have a man in our intensive care unit at our hospital right now who he actually came from Central America, I guess in South America, northern tip of South America. He ingested paraquat, and he couldn't get care there. He wasn't satisfied. He came to New York. He's been in our intensive care unit intubated now for a month. The probability that he survived is very limited. And we don't see many cases because we've prohibited it. But we do, the companies, Chevron and others, export massive amounts of it. And those really become an analysis. If you are interested, in pesticides, organic phosphorus compounds, or herbicides, you catalog what people are taking. It's really, the issue is prohibition. It's not treatment about thinking about treatment. We have no treatment for paraquat poisoning. There are a host of things that are proposed. None of them have been demonstrated to be efficacious. So that's a political act for all of you. That's what a poison center shows, the number of people who were poisoned, to collect that national data and really to say, what does that do? That only harms our young people and only harms the people who are depressed, and it's unacceptable to be available. So that's a big political stance that we take in the world.
Okay. I think, Geta, you had one more too, and then we'll conclude. Dr. Adlenta, I think if you're in the room, you are asking if you could reflect on this. I'm not sure if Dr. Adlenta is here from the ministry, but Geta, in the meantime, ask your question, and then we'll move to the next speaker.
Yeah. So my next question was, you said the the people who answer phone calls are nurses and I think pharmacists that you train them. Did it start as a voluntary basis for them to come and get trained, or did they have to apply through a special program?
They applied. They're usually, I mean, when we started, there were people who were called sanitarians. They were good about the water and the food in the city of New York, and they were not nurses or pharmacists. They didn't have clinical understanding of those things. And over time, we switched over and retrained people who we had already. Others dropped out if they couldn't pass the exams. And then we got younger people, and they came, and they all were hired as a full-time job, and they had to pass the exam, and they got a chance to do that over a period of time. And they had to then, they rapidly were mentored by the other faculty and the other information specialists, and it worked very well in developing the team. Across the country, there's great sharing there. Just as your national meeting, there's a national meeting of all of these information specialists. They have to take recertifying exams. They're all given, they have our textbook, and they have the faculty who teach it, like the people you'll see later today, are all involved with the training of the information specialists. So they're highly trained and very sophisticated in social sciences. They have to think about suicide. They have to think about risk prevention. They talk to the families to reassure them that, well, it's not so bad this time, but why don't you tell me what else is in the house that's a risk, and how do I put these things away to protect children? So I think it's their public health outreach. And then we see, as you commented, we have people who bring pesticides when they come from Bangladesh or China, and they're special pesticides. So we know if a child has a seizure in Brooklyn in a Chinese community, it's probably something called tetramine. That's a great rodenticide from China, but is not permitted here. And there's some pesticides that are available in South America that people bring, or from Bangladesh. So we know, in our books, we try to include the pesticides that are international and the people who use them elsewhere. So it is a universal problem, these things wandering in. And that goes to education in the community. I know they're probably cheaper, but one has to be able to demonstrate that it's riskier because they didn't go through the standards that we'd say that aren't going to kill a child. We think that, these things are, we talk about the things that are lethal at a single dose, and these are some of the things that are. So it's one, getting the listing of everything that you find and getting people to study it, and demanding, let's say, to get some assistance from your laboratories in the country or from the World Health Organization. That's the way you collect that data, and what's coming into your country that could be a risk. So
thank you.
How
long is the training time? 1 year, 2 years?
Yeah, well, it's 6 months before they could become functioning on their own, but they're working continuously with a supervisor for the first 6 months. I don't think it has to be a doctor. We don't want them to think so much about the tough medical stuff. We have people for that. We want them really to think about the human needs and what the family might be living and how to help them.
Okay, Dr. Goldfrank, I keep on saying, I'm sorry if you have to go, but I keep on saying one more question, and people keep on messaging me. You have maybe another 2-3 minutes. I'm going to just ask a couple of other questions, and maybe you can answer all together. Unfortunately, Dr. Alinta had to step away, but there are people from the ministry that have messaged me about some of the things about the roadmap. One question from Mulugeta Samork in New York, he said, what can be done for slow and communal poisoning that come from contaminated food? For instance, in Ethiopia, there's a purposeful mixing of foreign materials with food, and some say there's an increase of kidney issues, I believe, I'm not sure if infection. And this is one question. The other one is some of the questions that people were texting me on my phone is, what was the experience of engaging other sectors for prevention of poisoning and other injuries, especially when it comes to the establishment of and strengthen emergency care? Is there a roadmap document for development of comprehensive toxicology service that we can use for recommended approach, especially looking at standalone toxicology treatment centers versus, like you described, the central poison information centers, and maybe looking at, I think, from your experience in other countries as well, to document on that, and if there's any evidence that supports for establishment of a treatment center versus an information center. So these are all the questions being thrown out. I'm sorry, but this will be all the questions.
That's a whole day's work. I mean, I think that you could share some of the chapters from your textbook, our textbook, which have poison center issues that Bob Hoffman, who you're going to meet later, has been involved in these. Some are very tough questions. There's no problem in having a poison center with the treatment center right next to it. Some people do it that way in the world. But, you know, the question is, you have an enormous country the way we do. We have hospitals. You know, if the treatment center isn't in the right kind of hospital, it doesn't make much difference. The poison center can stand by itself. If you have a treatment center, you've got to be integrated into a hospital that handles all sorts of tertiary management. You know, intubation, ventilation, dialysis, a host of things. Whatever this highest standard of care, that's where you want your poison patients to be. It doesn't necessarily mean that's the best place for the public health approach. It's the battle over the public health approach is essential. You will never be able to treat the severest of poisonings effectively because they come too late. So emphasizing prevention for a country seems to be the ultimate accomplishment. That's what we learned first in America, that everybody would like to have the fanciest things, but we started with the simplest things and made great progress because we changed the laws. And the idea of what you control, you know, all the questions people have about things that come in and get into people, you have to know what's going on. You can't wait for the rarest cases that come to the hospital for poison treatment. You've got to know what's going on for the common cases that are occurring in the home and the community. You've got to have that, what the community educator does. They go to learn how people prepare their food, how they wash the materials, what's the quality of the water, is there lead in the pipes, is there paint that's leaded? You know, the pesticides and contamination of food certainly happen across the world. Those are big epidemics, but we miss all the others that are going on because we haven't really got a good public health structure. And I think that's what, and science should be able to, she went to Columbia to learn public health and policy. This is exactly what we teach in a course. We have a course that we do in Ghana and Nigeria twice a year, creating young investigators in the community, and really to try to establish a system for working on these principles and how to look at exactly what I tried to say in the introduction. Think about the problems that are happening in your community. Think about the things that aren't being addressed. Find some of those to work on. And those become great projects for you as individuals as well as for society. And that's what we built. When people used to say in Ghana, I've been going there for this project for about 12 years. People would say, you know, we can't do research in public hospitals. We can't do research in our country because it's too poor. So I would say, well, I come from a public hospital where they also told me we could never do research. But we've done remarkable research. And our team of workers have become some of the experts in the country and the world. On the woman, Kelly Duran, who's our worker, she said, I want to work at Bellevue because I want to prevent homelessness. I don't want to treat homelessness. I want to find out a way to stop that and to find the solutions because it's cheaper for society. And she and her collaborators have just published a book sign that you could get. It's called Social Determinants of Emergency Medicine, Social Emergency Medicine by Kelly Duran and Maria Raven. You know her as well. So it's a great textbook and it shows how to look at these issues. From Susie Vasala writes a chapter on prison health or the heat. So the problems you face, you know them better than anyone else. Then you have to see who are the people getting into these problems and how do you look at it. And so it's really, one of the things I said in the beginning was that this guy, Bill Haddon, set up these matrices to look at how to think. So if you think about the problem you have, you put that in these 3x3 matrix, pre-event, the event, and the post-event, the agent, the host, and the environment, you're going to have a lot of starters on how to do the research. But the second part, what I said was the United States established the Consumer Product Safety Commission. It said, we're not going to let something on the market unless it meets standards. That worked pretty well until we got a bad president who didn't want anybody to do that because it was going to have an adverse effect on industry. But we have to have that in government to control the protection of people through structure, and that's what this did for us. And we said, you know, the Consumer Product Safety, the Environmental Protection Agency, all of these are really to look at protecting the welfare of the total population, to looking at the problems that we see. And, you know, I think I would say these are all structure of a government to try to protect the people. And most of these things will be done outside the hospital. We can't wait till they get to the hospital. They're often very sick then. If we do, think about the things that bother you most. And that's really what I tried to start about. Everybody should find something that he or she believes is very important and they'd like to change in the world. And those are the things that get done. It can be done. And that's what you use your wisdom and intellect and questions that you've all raised to say, that's a problem for me and I need some help in modeling it. So that's what others can work on. And many people are happy to talk. People you have on the conference, everybody would be happy. You had a good idea about a poisoning strategy, we'd be happy to help and talk about it. And Cyan can link things up. And the public health approach is, I think, where we have to make progress.
Thank you so much, Dr. Goldfrank. A lot of people have been texting me.
For the
I'm sorry.
terrible trouble with the system, but tried. We made up, hopefully made up for it. So have a good meeting.
Thank you so much, Dr. Goldfrank. So many people have been messaging me and texting me, and also, as you can see in the messaging, they've been very inspired by your discussion and talk. Dr. Goldfrank has been, willing to come and talk to us. I'm pretty sure he'll come and talk to us again in the future for all the questions that you have. And I think just some of the takeaways from him that he's talked about, even in a small or resource setting area, I think there's a role for everybody. There are things that you can do in your environment. Especially for us physicians, nurses, people in healthcare, really teaching about the prevention. It's the poor man's treatment for really the toxicology emergencies that we see, and a lot that we can do with what we can with our education is really to teach others on prevention, and also to be able to have generate some of the evidence so that you can use this evidence to advocate for what you are trying to teach and also what you're trying to establish. Unfortunately, we didn't have any representation today from the ministry right now, but I think there's a lot of opportunity to collaborate. And also, Dr. Goldfrank, just to tell you, there have been over 80 people that have joined from different places all over the country. In Ethiopia, you see people joining in groups. So we're probably having, we probably had over 100 to 150 people joining us today to listen to this conversation. So hopefully everybody has learned something to take and to implement. And for the future, I think Dr. Goldfrank will come and talk to us about advocating for emergency medicine and the challenge that you're facing and how you can somehow learn to overcome some of the challenge. So with that, I know we're really behind on time. So we have a great presentation from Dr. Lagasse, who is also my teacher and has been my mentor from NYU Bellevue when I trained there in residency. And Dr. Lagasse, as I introduce you, maybe you can share your slides so that way we can continue to have the presentation as soon as I'm done the introduction. So Dr. Lagasse is an attending physician in the Department of Emergency Medicine at the Harbor Health Veterans Administration Hospital in New York City. He obtained his medical degree from the State University of New York Downstate College of Medicine in Brooklyn, New York. After finishing residency in emergency medicine at the University of Maryland in Baltimore, he completed a fellowship in medical toxicology at the New York City Poison Control Center. He started to be part of NYU emergency medicine faculty as an assistant professor from 2010 to 2021 for over 11 years, working clinical in the emergency department and NYU and Bellevue. In addition to his clinical duties, he enjoys his prominent role in medical education, using simulation to teach medical students, residents, and fellows in the areas of emergency medicine and toxicology. His involvement with Physicians for a National Health Program began in 2001 when a first-year medical student. He founded a student chapter of PNHP at SUNY Downstate. With that, today he will talk to us about dyshemoglobinemia. Dr. Lagasse has been very excited to talk about this topic. Because of constraint of time today, he might only talk to us about carbon monoxide poisoning, but he is also glad to come back and talk to us in the future. So with that, I will hand it over to Dr. Lagasse. Dr. Mambo he is the president of ESEP, Ethiopian Society of Emergency Professionals. I was informed that he might want to say something. So if at any point you want to say something, Dr. Mambo, please proceed. But I will let Dr.
Thank you, Dr. Sion, for giving me the chance. Thank you, everyone, for attending. And I just want to say thank you for previous presenters, Professor. It was a wonderful presentation, and it was inspiring. So I hope this collaboration will continue, and it will help us in setting in our effort to set a toxin poisoning center in Ethiopia. As I understand, the center was dedicating most of its time in treating patients rather than the information. So we will correct, and we will try to improve to solve our problems and take it forward. And I hope the Ministry of Health and our Society of Emergency and Critical Care Medicine will take this collaboration forward, and also Professor will help us. I think the impact of poison control center, how much it reduces the cost, ambulance cost, and hospital visits, it will be much more helpful in Ethiopia because of the high burden of pesticides, which the exposure will be at the rural areas where people may not get appropriate treatment or early visit to hospital. So the impact of poison center will be much higher in Ethiopia. And just to say thank you, and I hope this collaboration will continue with the Ministry of Health, the team from US, and from our society. And our society is happy and ready to collaborate, and any projects which are being done in other African countries also can come to Ethiopia, and we are happy to support. Thank you very much. Thank you, Sion, for giving me the chance.
Dr. Lagasi, I'll let you have take over.
Sure. Thank you so much, Dr. Firu, and everybody here. It's really quite overwhelming to be invited to this conference. I actually wish I could be with you today in Ethiopia. Dr. Firu, Dr. Goldfrank, Dr. Hoffman are really three of the most amazing physician colleagues and people I've ever met in my life, without a doubt, in my career in emergency medicine and toxicology. So it's really special to be with all of you here today. So I'm going to talk about hemoglobin toxicities. And Dr. Firu, just a quick check, is everything okay with slides and my sound?
Yes. Can you just advance your slide just to make sure that it's
Yep.
okay, great, we can see that.
Great. So if you've ever been to our poison center, we have a huge periodic table in the toxicology room. This is really how we spend most of our time thinking. So to frame this discussion, we're actually going to be talking about just a few different elements: iron, carbon, oxygen. As you know, these are really the vital elements for life, where most things are based on, that we depend on our daily physical activities and well-being. So it's really fascinating that small changes in any of these elements will lead to significant problems and toxicity. I'd also like to just highlight again, when I became a medical student and a doctor, there was always so much put into the patient's pulse oximetry. You know, the patient's pulse ox is fine, so they must be fine. I'm going to show you today that we often depend too heavily on the pulse ox and can often lead to downfalls. So a quick case of a person with a bad headache. You have a 71-year-old woman who comes into the emergency department. She's complaining of headache and viral syndromes for 3 days. She's waiting in the emergency department for 4 hours to be fully seen. By the time she's seen, she says her headache is better. She feels better. She wants to go home. Her vitals and her physical exam are unremarkable. She's discharged home. This is her room here. And the next morning, a neighbor rings the doorbell with no answer. Unfortunately, they break down the door and they find the patient completely comatose with a pulse, but with severe neurological deficit. She is unable to respond to pain. She's intubated and she's transported to the emergency department. They get a CAT scan of the head, and they see these abnormalities on the brain, on the caudate nuclei and the globus pallidus. And it turns out, looking back at her bedroom again, maybe some of you might notice there is this device right here. This is a propane space heater. We'll talk a little bit more about that. So what happened to this patient? Many of you probably imagine this is carbon monoxide poisoning. We're going to talk mostly about acute carbon monoxide poisoning, but I've found some relevant information for Ethiopia as far as public health and chronic carbon monoxide poisoning. So I'm be interested at the end of this for you to tell me more about this topic for you as clinicians. So want to make sure that after we talk about this, you recognize the common and some uncommon exposure sources, discuss how you'd evaluate a patient, and we'll discuss some treatments, including hyperbaric oxygen. Some folks say that carbon monoxide is, quote, the perfect poison. You can't see it, you can't smell it, you can't taste it. By the time it's poisoning you, it can be too late. And again, when you think about it, it's just carbon and oxygen. Again, vital elements of life. And by a triple bond, it is causing something that is so deadly. In fact, so deadly, it's still one of the top killers in the United States each year. There was a study a few years back noting almost 500 deaths per year related to unintentional and non-fire poisoning. But it's not just the United States. Carbon monoxide is still recognized as one of the top, if not the top, unintentional poisons that kills people each year. There are some really unfortunate and disturbing epidemiological events throughout the world, specifically in Korea in the 1960s and 70s. They were averaging nearly 3,000 deaths from carbon monoxide poisoning a year and 1 million admissions to hospitals. And if you know a little bit about what was happening at the time, most of the homes in Korea were heated by what's called an ondol system, or an ondol is a warm stone floor. And what happens is there is literally a fire that's built underneath the house, and it travels to different parts of the kitchen, different parts of the bedroom, living room, and there are often these charcoal briquettes that you can see on the right that are heated. Whenever this is done in a faulty manner or there is poor circulation, a significant amount of carbon monoxide leads into the home, and many homes are connected to one ondol heating system. And so this led to thousands and thousands, as I said, millions of exposures over years to carbon monoxide. Anytime there is combustion, anytime there is burning of carbonaceous material, you can get carbon monoxide toxicity. Here are some of the common causes. If you have, again, a blocked exhaust system, if you have a fireplace, again, that is not working properly, we have different water heaters and clothes dryers in homes and furnaces that can have significant carbon monoxide toxicity associated. If you have a garage and you're running the car, and then that leads to exposure in the house. We see a lot of folks who are doing indoor grilling and heating, and then again, that is going to lead to significant exposures. In the United States, we think about house fires being one of the major causes, but again, there are so many other causes. This is the propane heater. We unfortunately see this during the winter months. If someone's home heat is not working properly, they fill these space heaters with propane. They're often not very of high quality, and if there is not good exhaust, there is going to be a significant amount of carbon monoxide released into that space. Now, it's a bit of a trivia, but we do see this once in a while. You can actually, quote, eat carbon monoxide and get exposed in different ways. So there is a paint stripper or degreaser called methylene chloride. This is something that gets bioincorporated into your body, and the liver actually converts it to carbon monoxide. So what do I mean? You could be using this and inhale it, or it can get on your skin, and then several hours later, you can have a significant carbon monoxide exposure. Now, in doing some research for this talk, I found a few papers of interest for this group, obviously. This one study just last year in 2020 looked at indoor concentrations of carbon monoxide in residential buildings in Gondar town in northwest Ethiopia. They looked at 384 homes, and they found that over 58% of them had carbon monoxide concentrations above the permissible value. Now we'll talk about toxicity, but for the obvious reasons, the authors noted that if you're closer to the road, if there is no separate kitchen, if there's a large amount of burning of biomass, again, charcoal briquettes, wood, other things in the home, there's going to be a higher risk of being above the permissible threshold. This is also a very interesting study. It's my understanding that there's huge, wonderful tradition of having coffee in Ethiopia, and these ceremonies, I understand, can be daily and happen several times through the day. So this study looked at folks who are preparing the coffee, and they had them wear essentially carbon monoxide and particulate matter devices to measure the ambient carbon monoxide level in the air. So if you can see around these people, there is around their neck, there is this carbon monoxide device, measuring device. And what they saw is that 15 and 30 minutes and 60 minutes after this coffee ceremony, which, as all of you know, involves roasting of the coffee beans and burning of materials in enclosed spaces, that many of the folks in the highlight in the yellow were above the WHO guideline for carbon monoxide, and the blue was double the level. Now, we'll talk mostly again in a moment about acute exposures, but chronic exposures, we believe, because how I'll explain this affects hemoglobin oxygen transportation, can lead to heart attacks, potential effects on fetuses, and other long-term cardiovascular toxicity. The last thing I'll mention, in this study, they looked, or this was really more of a report rather than a study, in that Ethiopia is one of the cities in Addis Ababa has one of the highest carbon monoxide levels in the world. And a lot of it is believed to be the vehicle emissions. And I know there's a lot of political and other discussion around changing the cars, changing the catalytic converters, and making cars cleaner and safer for everybody in the environment. So many of us cook for many hours in enclosed spaces, and we don't get significant carbon monoxide poisoning. So what's happening? Well, I want you to look at these two images. The image on the left is a nice, beautiful flame, orange, red. You can imagine you're watching a fireplace or a campfire, and it's crackling, and there's smoke and other things coming off of that. And then there is this stove fire on the right. Kind of boring to look at, right? Has this blue tight flame. So why am I showing you this? Both are undergoing combustion, but the combustion on the left is what's called more inefficient or incomplete. So the combustion on the left is going to release a significantly greater amount of carbon monoxide. The combustion on the right is almost insignificant or not clinically significant. So when you see combustion that is, quote, inefficient, you have to think of carbon monoxide. So what's the pathophysiology? I know you've all heard this before. Just to remind you, carbon monoxide binds to hemoglobin 200-300 times greater than oxygen. And it also impairs the unloading of the hemoglobin to myoglobin to deliver oxygen to your tissues. If you remember from biochemistry also, anytime you shift to the left, you have worse oxygen delivery. So carbon monoxide, in addition to pushing off oxygen, also lets or prevents the regular hemoglobin from delivering oxygen efficiently. So when you look at oxygen saturation versus oxygen content, this is the problem of just looking at the pulse oximetry. And bear with me a moment. This math, I'm not trying to scare you. We're not doing high-level algebra here. I just want you to look, for example, take a healthy young person with a hemoglobin of 15. They have a partial pressure of oxygen over 100, and their oxygen saturation is 100%. This is hemoglobin that is bound plus dissolved. This is that equation. And what you see is most of our oxygen, that 15 times 100 times a constant of 1.39, in our blood is bound to hemoglobin. We all know that the amount that's dissolved in blood is very small. And this will be important later when we talk about hyperbarics. If someone is anemic, let's say 50% of that normal 15 grams per deciliter, well, in the equation, it's literally half. So instead of 15 times 100% and 1.39, it's 7.5. Now you see that your percent volume, the amount of oxygen that's carried in your blood, is literally half, because that amount that's dissolved in the blood is so tiny and negligible. So here is the big thing that I want you to take home. I want you to think of carbon monoxide toxicity as what I call a functional anemia. If somebody's carbon monoxide concentration is 50%, that's as if they have 50% less hemoglobin emergently in that moment. And there are even worse effects to that. Oftentimes, I liken this to being in the trauma bay. If we were to see somebody and you were told, okay, they lost 25, 30% of their blood volume, you'd be rushing into them and you would think they would look very sick, right? They would be very symptomatic. The carbon monoxide is very difficult at times to pick up on the diagnosis. Acute toxicity, again, just simply inhibits oxygen delivery, okay? That is the main thing that is happening here. Now, with my mentors, Dr. Goldfrank and Dr. Hoffman, we often talk about this dog study. And I'm a dog lover. I have a dog in the other room. So no offense to any, animal activists. I didn't do this study. This was done almost 45 years ago. They took several dogs and they had them breathe 13% carbon monoxide. They all died within 1 hour, and they all died with a level of about 54 to 90%. They took that blood and exchanged transfusion, meaning took that blood and transfused it into other healthy dogs who were not CO exposed, and nothing happened to those dogs. So again, the dog that died initially had a 50% carboxyhemoglobin. They transfused another healthy dog to 50% carboxyhemoglobin and nothing happened. They did hemorrhaging of that same anemia level, also nothing happens. Why tell you about this? Well, just from the carbon monoxide bounding to hemoglobin and that acute toxicity does not explain the toxicity alone. So what we have here in chronic toxicity is really a large cascade of other hypoxic events. Events that lead to oxidative stress, events that lead to lipid peroxidation. When you hear that, that's the breakdown of nerves and many other ways that we transmit neurological function. So this is why long-term, either chronic toxicity or acute toxicity that leads to chronic toxicity is occurring. All right, if I haven't convinced you it's bad enough already, what we want to know, how do we diagnose it? And I'll tell you, this is one of the greatest challenges for emergency physicians, clinicians, nurses, all in healthcare, including medical toxicology, because the symptoms are so variable, and ultimately you have to have a high suspicion. Meaning you have to think about this with so many different presentations. Now, you'll look in a textbook and they'll tell you mild symptoms is nausea, vomiting, medium is severe headache, extreme is unconscious. You know this. You know that if somebody lost 25% of their hemoglobin, they would start to feel ill. And that's how you should think about it. Again, it's a functional anemia. A lot of textbook will try to have you memorize these levels, but I don't think that's very helpful. Okay, because you really have to take it into the context of what is the person's baseline hemoglobin. If their hemoglobin is 15 and they have a 10% carboxyhemoglobin, well, and they're young and healthy and have no comorbidities, they're not going to have as much symptoms and toxicity as someone whose hemoglobin is 7 and have other cardiovascular risk factors. So again, this is an acute dysfunctional, or what we call dyshemoglobinemia sometimes. So in that case that I presented, the patient had let's say, a carboxyhemoglobin of 30% when they presented to the ED initially, but their oxygen saturation was 100%. How is this possible? This is the downfall of the pulse oximetry. It only measures two wavelengths, oxyhemoglobin and deoxyhemoglobin, and that's it. So I had a patient one time, probably the sickest anemic patient I ever had, whose hemoglobin was 1.3, and their room air pulse oximetry was 100%, because that 1.3 grams of hemoglobin that they had was pretty much all saturated with oxygen. But as you all would imagine, that patient was in extremis and near death. When you look at the way pulse oximetry works, there is an issue with carbon monoxide. It does not, it basically gets confused because it passes at similar wavelengths. So the only other option that we have is we have to do what's called co-oximetry. It takes a closer look at different wavelengths and then can give us an estimated value of carboxyhemoglobin in addition to oxyhemoglobin and deoxyhemoglobin. So what are some of the treatments? I will tell you right now, the number one thing that you can probably do in the public health world is remove the person from the exposure. The first thing you can also do in the hospital setting is find out who else is exposed. We had a remarkable case of a young woman who came in with headache and flu-like symptoms, body aches, but didn't really have fevers, sore throat, cough, anything else that you would expect with a viral syndrome. It turns out the emergency physician at our hospital did a great job by thinking about who else is there and found out that the children were also in the pediatric emergency department on another side. And that the spouse who was with the patient was also having a bit of a headache. It turns out they were all being exposed to carbon monoxide. And it's no doubt in my mind, if we did not catch this and we would have sent them back home, they all would have probably died because there was a huge carbon monoxide leak in the heating system of their home. So removing the person from the exposure, ensuring that others are not at risk is so critical. The next thing that you've probably heard is we're going to put somebody on 100% face mask non-rebreather and give them as much oxygen as possible. And we'll talk about hyperbaric therapy, which I know can be limited throughout the world, including even parts of the United States. So what is it about hyperbaric oxygen? Well, on room air, the mean half-life of carboxyhemoglobin is about 240 minutes. On a non-rebreather face mask with 100% oxygen, it's about 90 minutes. And when you give someone hyperbaric oxygen, it's about 23 minutes. So in my mind, just to kind of think about it in certain numbers, in 3s and 9s, I think about 300 minutes, 90 minutes, 30 minutes. Why hyperbaric oxygen? Okay. Well, you can give huge amounts of partial pressures of oxygen. So that amount that's dissolved in the blood now becomes a clinically significant amount that can provide the tissues with enough oxygen. So you can see here, if we change that number of dissolved from 100 to 1500 in hyperbarics at 3 pressured atmospheres, now that's 4.5% of the volume of oxygen that can be carried. There are a few different types of hyperbaric chambers. There's one where the patient goes in individually and it's sealed. And there's others that's called a multi-place chamber, where multiple patients can be placed in one chamber. Nursing staff, physicians, and other healthcare professionals can be in there to monitor patients, to give medications, etc. So when we give hyperbarics for carbon monoxide poisoning, if someone is having an MI or a stroke from acute toxicity, this will help them because now this will give them enough oxygen. But it isn't actually where the studies come from to give people hyperbaric oxygen. In fact, most of the indications for hyperbarics are some kind of neurological dysfunction. So if we see someone with syncope, coma, that's going to be an indication. If they're having active chest pain or a heart attack, that's an indication. We often give it to people who have a carboxyhemoglobin above 25%, and for pregnant women and children above 15%. Now, if you read any of this, some people get hyperbarics up to 12 to 24, 48 hours later when their carboxyhemoglobin is back to normal and negative. And so why is that? This is getting back to the secondary effects of carbon monoxide toxicity. There are these huge, again, inflammatory cascades that cause significant neurological injury. And we call these chronic effects delayed neurologic sequelae or delayed psychiatric or neuropsychiatric sequelae. And I would refer you to New England Journal of Medicine 2009 Weaver paper. It just is a beautiful image here. You have to really zoom on it and look at it, and it shows you all these different effects and inflammatory cascades where carbon monoxide causes significant neuronal and other toxicity. So what are these delayed neurological and what we call sometimes neuropsychiatric sequelae? Well, the first is very simple. You think of someone who's post-stroke, right? And they can have some dementia, they can have paralysis, they can have other direct neurotoxicity. The other are more subtle is they might have changes in their memory, their mood, and concentration. And these are very difficult to measure, as you can imagine. I want to just show you one of the tests here that someone might go under in a study, either right after they've been exposed to carbon monoxide and then weeks and several months later. This is called the trail making test. And what they ask the patient to do is find the number 1 and draw a straight line or draw a line without picking up the pen or pencil until you finish all of the numbers to 25. And the speed at which somebody can do this test gives some information about their neuropsychiatric functioning. And so these are the tests that have been used to study hyperbarics, and there is a huge amount of controversy in the literature. So we have a couple minutes left, and I'm just going to highlight that, and then we'll have some time for questions. So the two big papers that we've looked at now for many years, and these are older papers over 20 years old, and there have been newer papers, again, very controversial if hyperbarics is indicated. Scheinkessel versus Weaver. Weaver's paper was in New England Journal of Medicine 2002. They took patients who were exposed to carbon monoxide and had acute symptoms, and they gave them, in these charts you can see here, different, quote, chamber sessions. So they bring you up to a certain pressure, give you 100% oxygen, then bring you down, and then that's over 2 hours essentially here. That paper looked at the neuropsychiatric testing post-carbon monoxide exposure and then 4 to 6 weeks later, and that said that hyperbarics works. It found that people who got a hyperbaric treatment had less of those unfavorable neurological outcomes months later. Now, we often ascribe to this paper, and that paper is from the United States, and it's not that we're partial to our own country, it's that the exposures in this paper, which I'll contrast to the next, are more typical of the ones we see. House fires, faulty heating, and this paper had very good follow-up. The conflicting data comes from a paper from Scheinkessel et al. In Australia. And they found actually hyperbarics, if not only did not work to prevent these neuropsychiatric sequelae, it actually seemed to be worse. Now, they did different hyperbaric treatments, and most of their patients were post-suicidal, which we think is a very rapid increase in carbon monoxide toxicity and then a rapid decrease, which may be different from someone who's in a house fire or a home with a faulty heater and is there for several hours, maybe even a day. Now, they also had a lot of patients lost to follow-up, almost 50%. So who do we believe? Well, I honestly, as a toxicologist, I'm quite frustrated still with the literature because there's no standard on the consensus of the time from exposure, what type of exposure, and really what type of treatment. It's like saying if we were comparing pneumonia treatments and someone said, well, I'll give ceftriaxone 500 milligrams and I'll give ceftriaxone 2 grams every 3 hours. the differences are really sometimes too broad to apply and compare. And if you look at the Cochrane review, and many of you, if you don't know this, this is a database that looks and tries to pull in meta-analysis of poisonings, of other treatments. They are very anti-carbon monoxide, hyperbarics for carbon monoxide. And part of that is they hold a high standard of poisoning, or really their evaluations to be double-blinded and placebo-controlled. And as you can imagine, it's nearly impossible to placebo and double-blind hyperbaric oxygen and toxicity, because you're going into a chamber, and obviously you can't just poison people and see what outcomes happen. So very difficult to assess that. You know, in the end, one of the last couple of things that I want to mention is, if you have ability to test for co-oximetry wherever you are working, you need to have a low threshold and be liberal at sending carboxyhemoglobin concentrations. This was one small study during winter months, and they took 37 patients who had a headache, and 7 of them were found to have carboxyhemoglobin concentrations above 10%, and none were suspected of having CO poisoning. I don't know if many of you have been using the co-oximeters, so that can give you carboxyhemoglobin with a finger device similar to, you know, pulse oximetry. And, you know, I think what we're going to do is stop here. And again, I think what's so fascinating, again, about toxicology is we've really just talked about 2 elements, carbon and oxygen. And we obviously know carbon dioxide is something we breathe off, very little toxicity essentially, and something carbon monoxide, a small change, is one of the top killers worldwide. So please remember the downfalls of the pulse oximetry. It tells you nothing about the patient's ventilation and true oxygen delivery status. It only tells you about the percent of deoxy and oxy. I'm going to stop here. This is my email, toxdanny@gmail.com, pretty easy to remember, and I'm going to stop sharing. And hopefully we have a few moments for questions. And thank you all very much.
Danny, thank you so much for that great and succinct presentation. We had an idea, and Bob Hoffman had agreed to this, to have his presentation and then combine the questions. If that's okay with Danny.
That's fantastic. I was thinking that too. Yeah.
And I know you guys together are exponentially even more great.
No, not at all Dr. Hoffman.
So no. I think you guys have heard some of the discussions earlier where Dr. Goldfrank was around, so they might even pick your brain. Dr. Hoffman, I would like to say that Dr. Goldfrank showed a picture of you that was quite interesting, so people have seen a very younger version of you earlier. So as you put up your slides, I'm going to introduce you, and then we'll just have the combined, there are questions that are being typed on the chat. Dr. Lagasse, you can see, and then you can prepare your answers for later. So thank you, Dr. Hoffman. I'm going to introduce you, and then in the meantime, you can just share your slide. So Dr. Hoffman, Professor Hoffman, he's a professor of emergency medicine at NYU Grossman School of Medicine. He received his BA from Brandeis University in 1980 and immediately entered NYU for medicine and for residency. He completed an internal medicine residency at the New York University School of Medicine, followed by a fellowship in medical toxicology at the New York City Poison Center, Bellevue Hospital Center. He subsequently achieved board certification in internal medicine, medical toxicology, and emergency medicine. Dr. Hoffman has previously served as a director of the Fellowship in Medical Toxicology at the New York City Poison Center and the director of the New York City Poison Center. He has authored over 100 peer-reviewed publications and various aspects of toxicology. He's also authored numerous textbook chapters for major references, including in Dr. Goldfrank's Toxicology Medicine book. He's lectured around on various aspects of toxicology and has helped establish poison control centers in both Europe and Asia. Professor Hoffman has held offices in all 3 American toxicology societies. And I think that I've said enough about Dr. Goldfrank and about Dr. Hoffman, and all of them were my teachers in residency. and it gives me an immense pressure to have a glimpse of what I've received during my residency training. They've tried their hardest to make me smart like them, but it hasn't worked. So that's why I invite them to come and talk. So without further ado, I'll give the stage to Dr. Hoffman, to Professor Hoffman. I'm so used to calling him Bob, and
Bob. It is Bob.
But you know, he has all the great titles at NYU. So Bob, did you put up your slide? We don't see it. If not,
Oh, hang on. It thinks I'm sharing. Hold on, let me just try one more time.
if not, I think Salsa or Lemlem can share it. Did everybody see it? Was it just me or?
It was in, and then somebody else, I think, hijacked it.
Okay, hold on 1 second. Let's just see what we got here. No. There's always something with these things, and I apologize. Okay, a window up. Here we go. This is going to work. Yes?
Not yet. Do you want? Oh, there's what's coming up. Okay.
It's on
Can you just advance it? Make sure it advances.
Yeah.
We're good?
Bob, can you advance? Okay, I can see.
Yeah, we can see.
Okay, thank you so much. You can proceed.
Okay. Yeah. Well, thank you. It's truly an honor and a pleasure to be here. And just for Cyan, Dr. Furu, not only did you live up to our expectations, you've gone far further than anyone could have ever been imagined. And although you're a humble, modest, kind individual, we're all very, very proud of you. And so it's great for us to be here. I know we're a little behind and time is a little short, and so we're just going to go forward. And I'm going to go over the two major manifestations of organophosphate and carbamate poisoning, and really focus on the role of the treatments and the controversies that surround both the use of atropine and oximes, such as Pralidoxime or 2-PAM. But I think it's really important to start with a global overview. When you look at the entire world, people have estimated that there are about 2 million episodes of intentional self-poisonings with pesticides. And although this is a global problem, there is a lot of regional variation, with an extremely high mortality rate in the Asia-Pacific region. And this really largely results from a bad combination of having availability to highly toxic compounds, and in many of these communities, not only having limited healthcare, but having limited healthcare resources and limited funding and availability of antidotes. And you can see that the confluence of the most toxic compounds and the most stressed healthcare system can really result in substantial morbidity and mortality. Many people think that pesticides are the #1 global poison killer. I think everybody has their favorite, but they're certainly up there. Just a brief overview of the pathophysiology. To understand what these things do, all you have to do is remember everywhere that acetylcholine functions in the nervous system. So we have the parasympathetic system, where we have 2 synapses, both that require acetylcholine, and that's largely the vagus nerve. We have the neuromuscular junction, where a single synapse is responsible for neuromuscular strength, but also ultimately also with depolarizing neuromuscular blockade in excess. And it's also important to remember that on the sympathetic side, the first ganglion in a 2-ganglion system is a nicotinic acetylcholine receptor. And that's pretty much the same for the adrenal medulla, although there's only a single synapse. And the skin is a little bit confusing in that the skin is part of probably the sympathetic system, but really is innervated like the parasympathetic system. To understand what pesticides do, all you have to do is sum up all of these events, and you create a fairly classic toxic syndrome of organophosphate or pesticide poisoning. But it's important to understand how these things do this. The normal pool of acetylcholine is turned over unbelievably quickly to limit the effects of these nervous systems. And you have a variety of cholinesterase enzymes. For today, they're all really about the same, that rapidly metabolize acetylcholine into acetic acid and choline. Acetic acid goes off into 2-carbon metabolism, into the Krebs cycle, and choline is recirculated to make more acetylcholine as needed. Pesticides, and this is just an example, methylperoxone, have an affinity for that same enzyme, acetylcholine esterase. But when they bind, they inhibit the metabolism of acetylcholine, and acetylcholine is allowed to persist everywhere where normally its effects would previously been limited. Over time, this reaction becomes fixed and aged. And when aging occurs, the enzyme is finished. It is no longer functional for the rest of its existence, and you don't have new enzyme until your body synthesizes it again. Carbamates are ever so slightly different from organophosphates in that they don't age acetylcholinesterase. As a result, the injury is somewhat self-limited. But I always caution people that some patients who take carbamates can be profoundly ill, they can be fatal, and they can look just as sick as anyone exposed to an organophosphorus pesticide. The only real clinical difference is that they never have delayed neurological toxicity. And because of the limits of today, unless we get to it in the questions and answers, we're not really going to be able to talk about delayed neurologic toxicity. So ultimately, what does it look like? There is an acute cholinergic syndrome. And the best way to think about this is everything that the vagus nerve does gets accentuated. Salivation, lacrimation, urination, defecation, bradycardia, bronchoria, right? All of those things are part of cholinergic excess. People remember things like SLUD, salivation, urination, defecation, or sludge, GI and emesis, or dumbbells, defecation, urination, bradycardia, bronchoria. They're hard to remember, but I always reinforce for people that nobody ever salivated to death. Nobody ever lacrimated to death. The things that we're interested here most commonly and most importantly are bronchoria and bronchospasm, because the sick patients will drown in their own secretions, and depolarizing neuromuscular blockade. Again, think about this just like succinylcholine. Over time, people will either develop respiratory failure and or get better. And there's this delayed neuromuscular toxicity that maybe we'll get back to later if we have a little bit of time. There are 2 antidotes that we think about, atropine and pralidoxime. And pretty simply, atropine is the anti-muscarinic antidote. Everything that the vagus nerve does, atropine potentially reverses, but there's tremendous controversy and confusion about the right way to dose atropine. And the best discussion of this topic was from Nick Buckley and Michael Edelstein and all of these other people, a group out of Australia and Sri Lanka who spent a lot of time trying to study pesticide poisoning. And basically what they did is they created a hypothetical patient based on some real patients. And in fact, they created 2 patients, one who was moderately ill and one who was severely ill. And they looked at how much atropine it took to get that patient under control. And then they looked at standard references and evaluated the quality of the references' recommendations as to whether or not they would get an appropriate dose of atropine in a timely fashion. So what you see are a bunch of common references. The light gray bars are the moderately ill patient, and the darker black bars represent the more severely ill patient. And if you just look at the time to atropination, it's anywhere between a few minutes or a few hours up to the better part of a day. And what this highlights for you is that if you're drowning in your own secretions and you're waiting a day or a half a day to get the right dose of atropine into you, you're not doing a good job. And I'll also emphasize that many of the treatments recommended by the WHO involve these lower dose, slower treatments that are generally associated with not great outcomes. Their recommendations, which are the recommendations that most people have adopted, are to start with a standard dose of atropine. And it could be weight-based. This is adult dosing, but for a child or a small infant, you would use the dose of atropine that you're typically comfortable with. In an adult, that's somewhere between 1 and maybe 3 or 4 or 5 milligrams. But to rapidly escalate by doubling every dose every 3 minutes or so. In this way, you get the maximum dose of atropine in early with the endpoint of drying your secretions. Remember, if you're not going to die of tears, I don't care if your eyes get dry. If you're not worried about polyuria or GI losses, it's not about defecation. And I often hear that I can't give any more atropine because the patient's still tachycardic. Often the reason they're tachycardic is because they're drowning in their own secretions. So give atropine, give a lot of atropine, give atropine early and repetitively. And this is a nice study that actually compared the two regimens and looked at outcome. The green line is a very traditional incremental bolus, incremental dosing regimen, kind of the thing that would be recommended in a traditional WHO monogram. And the red line is what happens when you double rapidly. And if you look, oops, I'm sorry, I said that backwards. It's the other way around. The green line is the incremental bolus, and the red line is the normal regimen. And if you look at who's still alive, when you give a lot of atropine early, the patients in the green line tend to be alive many days after study. Now, I'm actually sad that we're late for time, but I'm actually glad that we're late for time because Danny introduced you to how we generally feel about the Cochrane reviews. And here's another example of where the Cochrane review was grossly misunderstood and is often misrepresented in the setting of pralidoxime. So atropine can only reverse the salivation, the bronchoria, and the bradycardia. But if you have neuromuscular weakness and neuromuscular blockade, you may end up intubated for days to weeks to even months. And the only thing that can potentially reverse that is pralidoxime. Here's a Cochrane review that looked at pralidoxime, and they looked at 7 studies. And again, exactly as highlighted by Danny, most of the dosing regimens differed. And although the highest dosing regimen consistently shown a benefit, when they combine the studies the way the Cochrane reviews typically do, they came up with a different conclusion. And these are their conclusions, not mine. The research did produce mixed evidence. Many of the studies had substantial limitations. That's a fact of life. And generally, these studies failed to support the routine use of oximes, but they kind of left the door open that there might be some situations when it was beneficial, and they called for more research. Here's the problem. This is a beautifully elegant study done by Kirti Pawar. She's an intensivist out of India. This is her hospital, and both from the outside and here from the inside, to get a sense of what she has available. She used a high dose pralidoxime regimen, 1 gram an hour for 48 hours by continuous infusion, versus a fairly standard WHO kind of recommendation of a gram every 4 hours for 48 hours. And that's even a little bit more pralidoxime than many people recommend. And when you look at the results that Dr. Pavard and colleagues established, they're really dramatic. Mean days ventilated reduced by half. Atropine dose dramatically decreased. Weakness less. Intubated at any time during the admission less. Intubated after randomization dramatically less. Survival 8% in the control group, 1% in the study group. That basically translates into a 7% absolute difference, which means that you have to treat 14 patients with her regimen in order to save a life. And all of these other things were improved. But because no one else in any other study used this dose of pralidoxime, all of the other studies failed. And it's not right to lump them together and make a single conclusion. This is a study, and again, these people are my friends and respected colleagues. They do gigantic work, and I'm happy to share a number of publications with Michael Edelson, with Andrew Dawson, with Nick Buckley, and some of the others. This is their controlled trial of pralidoxime, and here are their results. And it really looks like pralidoxime increased lethality. But I want you to note that most of the difference occurred more than a day after treatment, right? The lines are very much the same for the first day. And what I want to show you is this is actually one of their hospitals. And this is a represented pesticide patient that Andrew Dawson showed me, getting an awake lavage in a restrained position without a protected airway, subsequently dying here. And you can see the intubation fluid with frothy pulmonary edema. So my observations are that this study out of Sri Lanka is grossly underpowered for a negative study. They used a regimen of pralidoxime that isn't the right regimen, meaning the one that's actually proven to show a benefit. Many of these patients came to healthcare very late. The deaths occurred more than a day after the exposure, which typically is a failure of healthcare, not a complication of poisoning. And this was studied in a very resource-poor nation with very limited ICU. And when you look at all of these potential biases, it's not surprising that they found a failure or they failed to show a benefit. Many other people have looked at this, and all of these are misinterpreted. I trained Sage Wiener and Ian D'Souza, Adam Bloomberg. I know he rotated with us. Their results are honest, right? They compared atropine alone without pralidoxime to pralidoxime, and they looked at mortality and intubation and duration of intubation, and sure enough, they found absolutely nothing. But again, all of these studies use different doses of pralidoxime, and if you look at the references, you'll note that the paper by Curti Pavard, which didn't compare atropine with and without pralidoxime, they compared atropine with pralidoxime using 2 pralidoxime regimens, wasn't included in this study because it didn't meet their search criteria. So they've kind of misled people. And in their abstract, it says, they were unable to show a benefit, which is true. Their results don't demonstrate a benefit, but they go too far here in red and suggest that the routine use of pralidoxime in organophosphate toxicity is not supported by the currently available data. In fact, I've shown you some currently available data that would make me excited to give pralidoxime to a poisoned patient or really excited to receive it if I were to be poisoned. So what's wrong with this analysis? And I've kind of hinted about it before. It's never just about oximes. It's oximes plus a healthcare system. It's really naive to assume that all doses of oximes can be combined into one analysis. And Danny did this brilliantly with carbon monoxide. Just imagine, I have a drug that works for pneumonia, and I do a study that uses the right dose, and people get better, and half a dose, and people don't get better. And I combine the results in a meta-analysis, there's not going to be a difference. That doesn't mean that there's not a difference. That means that the studies were conducted poorly. And in many of these analyses, the absolute critical studies are ignored or dismissed. And I honestly believe that some people have created studies to show failures of pralidoxime because it is an expensive antidote and would be very costly in healthcare models where patients and family have to pay for the antidote. So maybe it doesn't work. And that's not the right answer. You can say it works, but we can't afford it. But the science ought to really be clean. So just in the last minute or two, let's just cover a couple of other issues. What about personal protection? This is the worst pesticide poisoning event that anybody could imagine. This is the use of nerve agent, soman organophosphate pesticide poisoning in the Tokyo subway. And here are a bunch of dead people. Here's the press and visitors or well people in no protective equipment whatsoever, and firefighters in routinely firefighting gear. None of these people got ill. It's an open air environment, but it's important to realize that just being around people who are poisoned don't put you at risk. This is the routine management of organophosphate poison patients in Asia. You can see that this gentleman's wearing gloves. All these people are wearing street clothes. Maybe there's a face mask here. The incidence of secondary poisoning is unbelievably small to the point where it's non-existent. This is how we treat pesticide poisoning in Bellevue Hospital. This is our large decontamination chamber. These are our suits that we wear. It is almost certainly unnecessary, as highlighted here by a consensus paper from the Australians that review all of the incidents of secondary contamination from healthcare workers. And it's really hard to find a legitimate secondary case. And whereas I encourage you to be careful and to use whatever protection you have available to you, the fear of treating somebody because you might get ill is actually not justified by the existing data. The final words, the public health is really important. There are some really very serious poisonous pesticides out there. And the WHO has classified them based on animal LD50, which seems to be appropriate for people as well. The only way to reduce illness and injury from these things is to ban them. And this is work that's largely stimulated by a Dane, Frederick Conradson, but also dealing with Julian Chisholm, and you'll see Michael Edelson's name here again. This is completed pesticide suicides in Sri Lanka over time. As the highest risk pesticides are removed from society, the lethality rate goes down without any change in crop yield or cost of fertilizing and pesticide application to crops. It is pretty clear that these things are not needed in society. So here's the summary. Atropine is the drug of choice. Give large doses, rapidly increase them, double it up to a reasonable point, and your clinical endpoint is drying of secretions. Animal and basic science data are highly supportive of oxime therapy. Most of the studies are underpowered or insufficient to overturn the single really good positive paper that I shared with you, the one by Kurti Pawar and colleagues. We continue to use and recommend pralidoxime as the only therapy for patients who have significant neuromuscular weakness. I already mentioned a couple things about carbamates. Don't think that carbamates are typically benign. They can be severely ill. And occasionally you'll see reference that pralidoxime makes carbamate poisoning worse. This is probably a false statement or a misleading statement. And I'm really happy to share this old paper with you that I did with Maria Mercurial from our poison center, Jason Hack, who's a toxicologist in North Carolina, and Annabelle, who was one of our residents at the time, really demonstrated in an animal model that when you use the right dose of pralidoxime in the most nasty carbamate, everything works out just fine. So I promised we'd stick to time, and it's wonderful to share a couple of minutes with you. I'll say thank you. I'll stop sharing my screen, and Danny and I will field whatever kind of questions we can take for as long as you want to talk to us. Thanks again.
Thank you so much, Bob. And that was very quite loaded, also very informational, compact in 30 minutes. And I'm pretty sure a lot of people will have questions as they type away. I will also let Dr. Lagasse come back and also answer some of the questions. I just have a very funny story to tell. When I was an intern on poisons, Dr. Hoffman's not going to remember this, but he was asked students and the interns, what's going to kill people if they get poisoned with organophosphates? And it was going around, and I was the first to answer. I was next to him, so he looks at me and he asked me to answer the question. So I said the bradycardia. So he still gave me a chance to say and taught me that no, it's a drowning and the acute respiratory failure that would happen from the secretion. So I'll never forget that day. So I know people have questions, and I will please mute your mics. Thank you so much, guys. So we'll do most of it on the messaging here and to the chat box. Lemlem had pointed about her friend's daughter who was exposed to cooking and charcoal used eventually. I think this is kind of discussed into what Daniel Lagasse was talking about, removing people from the agent as one of the first protections against any sort of poisoning or exposure. So I think, Danny, you were looking at the question. So
yes.
So the first question is, does living in a high altitude, which is the case in Ethiopia, which a lot of, we have the good runners because of that too. This is just pointing at Bob's. I know Bob's, comments about the Ethiopians running. So just say that, and then if the question to you, Danny, is if this has an effect on the onset of symptoms and treatment and high altitude. So I'm going to just shoot the questions at both of you guys, and feel free to chime in and answer.
Go ahead, Danny.
Sure. Thank you, Dr. Ferrer. And I actually cut and paste all the questions real quick, so I can quickly run down them if you want. So first thing, altitude. There's some written on this, and it's very simple. Think about what happens at altitude to your hemoglobin, oxygen carrying capacity. So in my estimation, we believe that you'd be potentially at more damage being at altitude and having carbon monoxide poisoning. I think the concern for folks who take care of people at altitude is the misinterpretation that can happen with, quote, altitude sickness and carbon monoxide toxicity. They both look similar. You're not getting enough oxygen to your tissues. So how do you differentiate that? So that's a great question, but there's really, again, it depends on someone's comorbidities, what hemoglobin they have to begin with, their cardiovascular functioning, so many difficult parameters. I see the comment that the 9-month-old daughter nearly died after being exposed to a household heater and charcoal for cooking, and that they were removed. Thank goodness for that and safe. I saw a comment, CO poisons are common here, especially in cold seasons due to indoor charcoal burning. And one of the participants said they had a case of coffee roasting in closed space resulting in poisoning. Question was, are there endpoints for treatment? We don't have tests. We don't have hyperbarics. Is it just face mask, oxygen? And then someone also in the same perspective was asking, we can't send carboxyhemoglobin concentrations. What can we do? Bottom line, I I think one thing, obviously, thinking about where you can get carboxyhemoglobin, something I've noticed in other areas of the world, the co-oximetry, the portable ones, have dropped in prices significantly, somewhere to like $500 to maybe a couple $1,000 to have one of those portable co-oximetries that's going to measure your normal pulse oximetry, your carboxyhemoglobin, your methemoglobin. So there are issues with them. They're not perfect, but they're very good screening tools. So I think that could be something to consider. Dr. Hoffman, do you have other thoughts and other colleagues around the world what they do?
Yeah, well, yeah, thanks, Danny. It's easy to find people who are sick, people who can't think well, people who have cerebellar signs, so they have finger-nose problems, or they have ataxic gaits, people who've had syncope after exposure. Those are really high-risk historical events, and it almost doesn't matter what their carboxyhemoglobin is. If you believe they're exposed, those people could be treated aggressively. Other markers of badness, making a troponin, having an elevated troponin in a setting of carbon monoxide is definitively associated with bad neurologic and subsequent bad cardiovascular events. So those people I would consider high risk.
Yep.
Signs of poor tissue perfusion, like an elevated lactate and things like that, are probably meaningful, but we don't really know what the numbers are. And other people are looking at things like lymphocyte to neutrophil ratios and a whole bunch of other things, but I'm not sure the data are sound enough. I think if I had somebody who was exposed and could not get a carboxyhemoglobin, and I was worried about them, but had access to hyperbarics, I would send them to hyperbarics. Absent hyperbarics, all you can do is your best to make the carbon monoxide go away, which again, as stated, is not the ideal goal, but I would provide as much oxygen as the person could tolerate, either a tight-fitting CPAP mask or maybe high-flow nasal oxygen, if that's available to you, just to try and clear as much as you could clear as quickly as possible.
Yeah, I agree with that. And I think last couple of things before we maybe move on to questions for Dr. Hoffman. Is it possible to have paraplegia? I've seen a pregnant woman who got paraplegic and later died due to sepsis. Absolutely. When you think of just any tissue hypoxia to parts of the brain, CO exposure can look like a stroke and can be permanent, oftentimes reversible. I agree with that lactate comment. Someone asked about that. Dr. Hoffman alluded to. We know it's up. There's some studies, there's just poor correlation. And so I think the other thing that, again, is not for prime time, it's not just areas of the world that don't have hyperbaric oxygen. We talked to a lot of colleagues in the Midwest United States where they would have to fly somebody several hours in a snowstorm to get hyperbarics. And so it's often not something that's done in the United States as well if you're in areas where it's not physically near you. Now, those monoplace chambers are more common. Some people actually buy them and have them in their home now, and athletes sleep in them. And last thing to say, nothing yet ready for clinical use that I would recommend, but there are people are looking at things like controlling glucose and giving steroids and maybe some other anti-inflammatory interventions that could potentially prevent delayed neurological sequelae, but I can't, in safe, advice, give any recommendations on that just yet. I'm hoping, we see some of that research in the next few years, but we don't have that yet.
Yeah, great. So, science, just to help with this discussion, I am a great fan of the Ethiopian runners, some amazing men and women. But please realize that these guys run for an hour or two. I can run for 5 hours. So yeah,
we'll have to see about that, and we'll also have to give we'll see about that.
and some of those altitude comments probably differ very much between someone who lives at altitude and is very well adjusted, who might behave like anybody else who's carbon monoxide poisoned, as opposed to one of us. If we went to altitude and got carbon monoxide poisoning, I think we would be much more severely ill, just because of the lower PO2, the failure to compensate, with 2,3 BPG and hemoglobin and all that. There are a bunch of really cool questions, and they're really kind of all about the same. So once somebody has achieved atropinization, there are two different schools of thought, and we don't know what the right answer is. Either you could just treat them intermittently. Say, I'm going to watch you, I'm going to look at your pulmonary secretions, and I'll give you more if you need it. Or some people start you on a very low dose continuous infusion, 1 milligram or 2 an hour, just to leave a little bit of atropine always there. The challenge is that when you give a lot of atropine to people, often they get very confused, and often they stay very confused for a very long time. So trying to find the sweet spot of just enough but not too much takes great clinicians. And it's a skill that most people have to learn by trial and error at the bedside. Along those lines, it's pretty clear that 1 or 2 sick people could exhaust the entire atropine supply of a small hospital. So there are some questions that relate to that. Glycopyrrolate makes amazingly good sense if you have that, because it does dry pulmonary secretions, but doesn't cross the blood-brain barrier. So you're less likely to make people confused and ill for a long period of time. And absent glycopyrrolate and injectable atropine, there's a question about diphenhydramine. And Steve Bird actually has an animal model where diphenhydramine works. Things that, anticholinergic, antimuscarinic is antimuscarinic. The thing that I always remind people of is that if you have an ophthalmology clinic, the atropine eye drops are unbelievably concentrated and they're sterile. And atropine is orally bioavailable. So that if I was in a situation where I ran out of injectable atropine, I would have no hesitation to give oral atropine eye drops. And in a really bad consideration, I might even think about IM, the eye drops, because they are sterile. I think it would be really difficult to try and think about giving that preparation IV without a lot of good data. On the same line, there's some discussions of neuromuscular blockade. So many people who are organophosphate poisoned who need to be intubated are already flaccid. And if they're already flaccid, they have their own neuromuscular blockade, and you don't have to give them anything else. And that's great. But if somebody's in the middle, if you're worried they're mostly wet and you're worried about losing their airway and you want to induce them, you can give them any neuromuscular blocker that you choose, whatever you're comfortable with, as long as you understand the pharmacology. So succinylcholine is metabolized by cholinesterases, and it won't be its normal 8-minute duration. It might last a lot longer. And the same would be true for mivurcurium, which is a non-depolarizing neuromuscular blocker that happens to be metabolized by cholinesterase, but not a lot of people use that one. So if you use rocuronium or vecuronium or one of the other non-depolarizing blockades, you would use it exactly the way you would normally use it. If succinylcholine is all you have, or that's what you're comfortable with, feel free, go ahead, but just don't expect them to be reversed in 8 minutes, because it would persist a very long and potentially very variable time period. If you don't have pralidoxime, and I saw somebody in the chats that they don't have pralidoxime, people should not die for a failure of pralidoxime if you can protect their airway and ventilate them. So atropine, 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 and as long as they're ventilating, let them do it on their own. If they become too weak to ventilate on their own, then you have to take over their airway and ventilate them. And it could be a long time, and we have to think about DVT prophylaxis and ventilator-associated pneumonia, critical illness, polyneuropathy, all the things that happen when people are intubated in the ICU for a long time. But if you can take good care of them, the expectation is that they will survive and recover. I think that's all I saw, unless somebody has another one.
Yeah, I think those are most of the questions addressed. I believe Gaetao Hassan has raised his hand. I will let him answer ask the question, and then I would let Lemlem and Walda Sambet see if they've received any questions through text message.
Thank you for the informative and concise presentation. Toxicology happens to be one of the things that's rising in Ethiopia. I just came back about a week ago. I spent 2 weeks in different regions in Ethiopia, and they all have concerns. They see a lot of toxic effects of, like I said, herbicide, pesticides, and one of them was organophosphates. I think I was told there is some plant that the people chew in Ethiopia. It's called chat, or chat we call it. And I think they use this organophosphate, and I think, I'm not sure if it's seasonal or not. They see a lot of toxic effects from that plant. It's spread, I think, on the plants, and they sell them. Maybe it's a rainy season, it washes away. When it's not in rainy season, I think the stuff stays on the leaves and then has a higher toxicity. What can be done in these cases? One is public health issue. Just, avoid using it if it's possible. Or Dr. Goldfrank said there are 3 different levels, like level 1, level 2, level 3 organophosphate. Maybe the third variant is the less toxic one.
Yeah, I think those are good points. When it comes to practice, I think we've all found that you can tell people what's good for them and they do whatever they want. So I think if you knew that it was a pesticide, then potentially encouraging them to wash before they dry the leaves. I mean, in general, the leaves are taken fresh because there's more active ingredient in it. But to wash aggressively before they harvest or market, would be reasonable if there's enough water there. And the dried ones would be a really bad problem. And in fact, some pesticides may be put on the dried ones to allow them to persist longer. But my understanding is most dried leaves are exported, and that people generally use fresh
ones.
Yeah, that's absolutely the case. And then, as you know, it's actually legal to use khat in Ethiopia, and Ethiopia is one of the main exporters of that. So a lot of public teachings and public health intervention needed for that.
And also regarding atropine use, I think the atropine comes in different doses, I believe. Some have higher doses. The one has 1 vial in 1 milligram. That's going to be, you have to break like hundreds of them to treat someone.
The cardiac arrest atropine is typically for adults is 1 milligram or maybe even 2. If this is a problem that you routinely treat, you have to find concentrated atropine. And 2 things are available. There's a dried powder that's made for reconstitution. And what's nice about that, it has a very, very long shelf life. So that if you don't need it, it's there forever. It really can persist for years. And then you can mix it up as concentrated as you want. And then there are more concentrated vials that are designed for other indications like this. But again, if all you have is these 1 milligram vials and somebody's sick, in the model I showed you about atropine dosing, the mild poisoned patient or the moderate poisoned patient was somewhere around 20 or 30 milligrams. So you're going to be breaking a lot of vials, and the severe one was double that.
Thank you very much.
Thank you so much. I think Mulugate has a question, and then if anybody has a question, please type away. We have 5 more minutes, and then we will conclude this, and I think Dr. Tasfai is presenting after this. So, Lemlem, can you unmute Mulugate, please? And my son, in the meantime, wants to say hello.
Hello.
Oh,
He's
so
making some background noise. He came for a snack.
Hi guys, can you hear me?
perfectly.
So I'm Mulugeta. I'm here in New York at Columbia. Dr. Getao and I have a project in Ethiopia where we do quite a lot of interesting things. So some of the the issues that have been raised today are mostly technical, but for Ethiopia it's mostly economical. And I keep mentioning these big problems we have there, including having general food poisoning, bad people doing bad things to food in general, a lot of kidney problems. Cancer is becoming very prevalent in the society, mainly because of, again, food contamination. So the solutions that work here in America are not directly applicable. So what can we do to kind of work with the economies? And this thing that Dr. Gita mentioned, like the leaf that people chew, is highly economical. I studied in Harar, where Dr. Gita just went. We have a new project there in Haromaya Hospital. That whole region, the economy is based on selling this stuff. And Dr. Goldfrank mentioned something called paraquat, which was banned a long time ago. I'm not sure what the government is doing about it right now. So the question is, how can we really work with the economy, and what is the best way to approach all of the general problems?
Yeah. From the pesticide standpoint, I think there's enough from other countries, from Sri Lanka, from India, from Korea, some of which are, I mean, Sri Lanka, parts of Sri Lanka might be most like your economy. They showed brilliantly, I mean, really nice models that if you just take the worst pesticides as a country and say, we're not going to allow these in, people still get poisoned, but they don't die. And there's no change on the amount that farmers have to spend to keep their crops safe. And there's no change on how many crops come in per acre. And I think when you demonstrate that to people, it's easy because everyone wins. Right? I mean, from a very, very simple intervention, from a pesticide standpoint, that's easy. From carbon monoxide, yeah, carbon monoxide detectors are not that expensive. And, it may be more expensive than most people could afford, but I think there are a lot of people in the world who might be willing to give you some. And partnering with, whether it's WHO or UN or just wealthy nations, to say, one of the things we're going to do is we're going to recognize that carbon monoxide is bad for the homes, and we're going to get you some carbon monoxide detectors. And that's something that could be studied, right? You bring them into a community, you look at the rates of poisoning, you look what the poisoning would have cost, and you see if the price of the detector on the front end save the expense and the morbidity and the mortality on the back end. And if you do that on a little scale and can actually demonstrate it, it becomes a very easy argument to increase that into a larger scale. And I think, the wholesale price, in America, we buy a carbon monoxide detector, it's $15 or $20, and the batteries have to replace every couple of years. That might be a lot for some people in other countries, but the cost of that is probably $1 to make. And getting somebody to be generous, I think, would be a great way to approach this.
I would just add to that, Dr. Hoffman, not getting caught in the literature or the data again, because there's even a little suggestion out there that enforcing carbon monoxide detectors in homes in the United States hasn't decreased the overall rates of poisoning. And I think that's so dangerous, because we hear too many cases of a whole family found dead in a home with either a non-working or no carbon monoxide detector. And so if you're going to tell me that that's not worth an intervention that's potentially life-saving, it's silly. I think also, just as was mentioned by Dr. Hoffman, Dr. Goldfrank, a little bit of education goes a long way. You know, opening up a window during a coffee ceremony or others, it's going to be fine. There's no reason to totally stop some of these activities. So recognizing even before the poisoning happens, as we all know, that's going to be the most powerful impact. You know, I have to highlight, someone wrote, you know, getting a good history and living situation is very effective. I tell you, every time someone comes into the emergency department, I ask, you know, what was happening when you had the symptoms you were having? We're so good at asking, like, you have a headache, shortness of breath, chest pain, fevers, chills. But we don't often stop and say, what were you doing? Who else at home has a headache? You know, I had a patient one time who said, I get a headache every time I, you know, get home from work. Usually you get a headache when you go to work, right? So they were feeling better when they left their house. And that's how we caught a carbon monoxide exposure. It really is sometimes some of those simple historical questions. Take me through what was happening when you had these symptoms and who else is around you. So really, before you even get to some of those higher level interventions.
Thank you both. I think, well, December is going to take over to introduce the next speaker. I know Dr. Hoffman has to go. He might stay another extra few minutes, and Danny has volunteered to stay a little bit more. So
yep, I can stay,
stay around. They've made, you know, themselves available to all of you guys. They've shared their email. They've given you great lectures. And just to let you, Bob and Danny, most of, you know, Ethiopia is a population of close to 110 million people now. And these are people that have joined outside of the city from other cities and from other regions that are even more under-resourced than the capital city. So they really appreciate your approach on really also using the poor man's approach to diagnosing, and also other options that you have outlined, and for you know, resource poor settings, and also from your experience in other places. And Danny, just to give you a bit of context, Ethiopian coffee ceremony is really embedded within the culture. Ethiopia actually prides itself for being the top exporter, and also believe that coffee originated in Ethiopia in a region called coffee. So thank you, Ethiopian, every time you drink coffee. And also that ceremony is really embedded in the culture. And just like you said, a lot of it is a teaching. I remember when I was little, my parents always made sure during this coffee ceremonies that the windows are open and that it's well ventilated. And I think the lessons from the all three speakers that we've had from New York, really discussing about the origins of the establishment of poison control centers, and also really how the advocacy work and most of the government level decision has happened through the advocacy work and through generating the evidence. So most of us here as academicians, especially people that are outside of the Ethiopia, could really help with the research and also the mentoring and the guidance, and to help develop this evidence within the local context, and also help decision makers and policy makers guide them. And I think one of the slides that Dr. Goldfrank showed is really putting money value on it. Politicians and policymakers love that, so to really use that to advocate. And me also wearing a bit of a ministry's hat, because of there's so many priorities in the country. There's so many, as Mulugeta mentioned, you know, because of the economy and because of other competing priorities. Also, unfortunately, you know, these things are not well highlighted, but I think we can do better, us as people who are educated in medicine, who can develop this evidence to convince the policymakers that this resource has to be allocated for this. You know, as an emergency providers, we are all pride ourselves in being at the forefront of caretaking. We see all sorts of emergencies. We've seen what injuries does to Ethiopia. Now you all see what poisoning does, the conflict, the war, COVID, all of it. We've been at the forefront of this, and we pride ourselves in that. But I think one of the greatest things is that we can be a spokesperson, and we can really advocate and also use that to inform, our family, our community, and also at a higher level. Now, especially in a time of social media, I think we can be very, very influential and advocate for this. I know most of you guys have done this, and also the society here has done tremendous work on this. So please continue to do the work, and really I would like to thank all of you guys, especially people in Ethiopia who are doing the hard work with the little resource, with really without all the support that you have. And I always tell all of you guys, and also listening to Dr. Goldfang and Hoffman talk to us about the development of emergency medicine, their challenges are very, very similar to what's happening in Ethiopia and in other places that are developing emergency medicine. But it is all about, doing your part for advocating for your patients and for your specialty. That will help us to get to where we are. And just to say, it's not easy also in the USA. Emergency medicine is being challenged in so many things. So it continues, but I think we're the true advocates for patients. We'll take care of them anytime, anywhere, despite their financial situations. So please continue to advocate, and this is a way how we can push for better care and for strong emergency medicine in general. So with that, I will pass the stage to Dr. Getao or Dr. Waldesambat to introduce the next speakers. I'll stay around for a bit, and then I have to take my son to pediatrician. So thank you, guys.
Thank you, Dr. Tzion. So thank you, everyone. The next session will be very short, and it will be very another last interesting session. So I'm gonna introduce Dr. Tesfaye Getachew Shaul, who is actually my boss as well as my colleague. I'm humble and honored to introduce him. He is emergency physician working at St. Paul as well as at Abed. He is assistant professor of emergency medicine, very interested on toxicology, and he's having good knowledge on toxicology. He's interested, and he will share us a very brief discussion on local knowledge in our national level cases. So the floor is open for you, Dr. Tesfaye. ይሰማል?
No, Tesfaye. Is he on? Maybe he has issue with the connection.
I hope he's in.
He's there, but I think he has connectivity.
Yeah,
Let's wait.
Do you hear me?
Yes.
Yes, of course.
Now we
Go
can
ahead, please.
Okay, the slide is it visible or not?
You didn't share.
It's not.
Are you able to share the slides?
Yeah, actually,
Can you proceed without sharing the slide, please, Dr. Tesfaye? Maybe you can proceed without sharing the slides.
is it visible?
No, you didn't share. Please go ahead without sharing the slides, Dr. Tesfaye.
All right. You can email it to us and then we'll show it.
What about now?
Tasfai, can you email or for me? I can share.
Yet not shared, Tasfo.
Or you can proceed without sharing your slide, please.
Okay, I will talk a few points. In the meantime, I will send you.
Okay.
Okay. So, sorry for the inconvenience. And I will just present a common toxicology emergencies. Common toxicology emergencies in Ethiopia. It is a kind of review of relevant literature. And so the objective of this presentation is to identify the social demographic characteristic of patients who come with poisoning and identify common poisoning agents in Ethiopia and determine outcome of patients with poisoning. So in Ethiopia, the prevalence of patients with poisoning is not well studied, but I try to review some of the literature, and the prevalence of patients with poisoning out of the total ED patients is around 1.5%. And so I have reviewed some of the literature, and I found one article which is done in Adama Hospital Medical College, and another study which is conducted in Ambo University Referral Hospital, and another study which is done in Debre Tabor General Hospital, and another study which is done in Desi, Gondar, Wallagga, and Juma University and Tukur Ambassa Specialized Hospital. And except the study which was done in Wallagga, other studies, the studies was just retrospective studies, except the study which was done in Wallagga. And the minute patients who come with poisoning was just around 23, and which is common, the more common in females, and which is also consistent with other study which is done in Kenya, Mozambique, and other studies as well. So just to summarize, common poisoning agents in our setup, which account to 60 to 70% is organophosphate and bleach, which is sodium hypochlorite, and other important poisoning agent, which is common also in our setup, is carbon monoxide poisoning. So so the study which is done in Adama Hospital, they put as common poisoning agent organophosphate, which is around 52%, and also the study which was done in Ambo University Referral Hospital, organophosphate accounts 53%. And what is special here, what is different from other studies, the study which was done in Debre Tabor General Hospital, the common poisoning agent which is identified in this study was rodenticides, which accounts around 57%. And other study which was done in Tukur Ambassa Specialized Hospital, which is done by McConnell and his colleagues, which was just published in 2010, a bit old data. The sodium hypochlorite was the common, which accounts around 43%. So when you see circumstance of poisoning, intentional ingestion is very common, which accounts around 73%. And common risk factors or causes for intentional ingestion incriminated where just conflict with family members, psychiatric problems, where the most common, which accounts around 70% in combined. So when you see the route of exposure, the most common route of exposure is oral, which accounts around 94%, and almost all patients with inhalational poisoning were due to carbon monoxide poisoning. So carbon monoxide poisoning accounts around 5% from all total poisonings in Ethiopia. When you see time of exposure to ED arrival, which is very important in patient's management, arrival time to ED within 1 hour after exposure just ranges from 20 to 39%. In average, around 30%. Only 30% of patients come within 1 hour of exposure. So when you see this figure, it is very small. So as you know, the first 1 hour is very critical to do just decontamination and other supportive care. So when you see our case, patients just come late. So around 70% of patients came after 1 hour of exposure. Regarding treatment, which was just described in this study, the decontamination, atropine, antacid, or proton pump inhibitors were given for patients for GI upset relief and oxygen and IV fluids. When you see the outcome of patients, just when you see the mortality ranges from 0.3 to 18.6%, which is the list is just reported in Gondar University Specialized Hospital, and the highest reported in Devra Tabor General Hospital. So in average, around 6.4%, the mortality rate from this study, what I get, it's 6.4. So it's a bit higher from other studies, which is done even in Iran, in Saudi Arabia. So the causes may be due to late presentation, due to the toxic effect of especially rodenticides and organophosphate, which is common in our case. So I will pass the specific causes in each study area for responsible toxic agents. So I want to talk a few pointers about the new emerging poisonings in Ethiopia. Just I will talk few pointers about aluminum phosphide and 2,4-D poisoning. So aluminum phosphide is very toxic and fatal agricultural pesticide. And the study which was done in 2021 at Falaga Hospital at Bahar Dar, it was a retrospective study which was done on under 25 cases. So the mortality rate reported due to aluminum phosphide was 31%. So the possible cause of death, which was reported in the study, is just refractory shock, multi-organ failure, and respiratory failure were just reported for the cause of the high mortality rate in this study. So aluminum phosphate, as you know, is agricultural pesticide. Usually they use it for just to prevent drainage from pesticides. So once it's in contact with once that's ingested, it will in contact with the HCl and the phosphingers will be released. So this phosphingers has a deleterious effect in the organ by inhibiting cytochrome oxidase, and it is very fatal. Probably you'll tell us more about the aluminum phosphide management. There are the main treatment for aluminum phosphide is just supportive. If they come early, just gastric lavage can be tried with potassium permanganate and other supportive treatments. And another study, which is done by our colleague, Dr. Membao, in 2017 at Avis Hospital, it was just an observational case series study, which was done on 7 cases in 2 months period. And in these 2 months period, there were 7 patients who come with aluminum phosphide. And from these, 5 patients were died, which accounts around 71%. And another new emerging toxic agent, which is also high rate of mortality, is 2,4-D dichlorophenoxyacetic acid. It is a herbicide, and the study was done in our hospital, Abate Hospital, by our colleagues, Dr. Brookheit. This study was just unpublished, which was done on 98 cases, and the total mortality rate in this study, it's not about 2,4-D. Generally, the total mortality rate in this study was just 10.22. Out of this mortality, 2,4-D poisoning accounts around 40%. So how can we decrease morbidity and mortality? So we need to have a prevention, a treatment, system development, and data management and analysis system. So it needs a holistic, and it needs also a high-level commitment from the Federal Ministry of Health, from the institutions, and there has to be also stakeholder engagement between agricultural sector and the Ministry of Health. So as a summary, poisoning in Ethiopia is most common in females and young age, and organophosphate and bleach or sodium hypochlorite is very common toxic agents, but bases are related with organophosphate, pralidoximes, and herbicides. So this is all. Probably you can raise questions, especially the new emerging poisoning agents like aluminum phosphide, 2,4-D poisoning. The management is mainly supportive, and this agents, which is used for agricultural just pesticides, they are just out of use in some countries, but in our countries it's used by farmers. So this is all. If you have any question, you can forward. Thank you.
Thank you so much indeed, Dr. Tesfaye. So the floor is open for few questions. So back to Dr. Zion, if you are around.
I think Zion left.
Okay.
Yeah, I have a comment here. This is Gaetao. Again, as highlighted by Tesfaye's presentations and from a recent discussion with most of you, it is a public health problem now. I mean, it's in every region. A lot of people are being affected. There is a limited opportunity to treat patients, given the resources. So the main objective of, everybody would be to do advocacy and raise awareness. And this has to be controlled. That might require also government intervention, what kind of fertilizers, herbicides are being sold, what are the sources, where do they come from, how available are they? I mean, if you can get a sack of fertilizer in the house, it's likely that the children will touch it and get poisoned. Or if you can buy it on the roads, on the roadside, between the bananas and oranges, and you take it home, again, the likelihood of poisoning is higher. So this is more like awareness and prevention seems to be the most effective way. It takes time, it takes effort, it takes a lot of collaboration between physicians, government agents, and also the media. The media has to, highlight this in between the shows, in between the dramas, in between the news. It has to be, expressed and emphasized. If Dr. Lugezi is in, he can maybe chime in and give his.
Sorry, can you repeat that question? I am here, yeah.
Oh, yeah, I was just saying if you have anything to say, like what we see here is a public health issue, and it requires some teaching, raising awareness, and being, advocate for the people. Like I said, if you can get this stuff in your house in a sack, children will touch it. Or if you can buy it on the street, in between bananas and orange, the likelihood of contamination will be higher. So it boils down to raise awareness and prevent rather than, treatment, because some of the drugs are not available.
Absolutely. Definitely agree with that. Yeah.
Hi guys, I'm also listening to the conversation here. I'm just traveling at the same time. But yes, I think I get what you were saying. I think I definitely agree with that. Most of the public health teaching and interventions are very important. And I think that's why you did an awesome job outlining the current issues in Ethiopia, which is very, very important for us to understand that and use the local context to teach people. One thing I would say is we don't have enough data and we don't have enough research on this, but I think it's important, even from the speakers today, there is an opportunity to collaborate and work together on this for research purposes. And really, the data is there. I think it's a matter of cleaning it and also putting it together for publication or for sharing. And really, I think all of us here have a big role in advocating and then teaching the public, starting from our own family members. That could go a long way. So that's what I would say. I don't know if anybody else has anything to add.
I would add to that, Dr. Firo, that, and I don't want to bring the mood down too much, but these are really societal failures that all of us should own, right? This idea that I'm in the United States, you're in Ethiopia, different resources, it's shameful. We have enough resources for everybody in the world. Dr. Firo is one of the leading educators on this, especially with what's been going on with COVID vaccinations. You know, there is no rational reason to not have the continent of Africa to be vaccinated at the rates of other, quote, wealthier nations. And to me, I say quote because what makes wealth, what makes a nation wealthy would be, for me, the health, the happiness and well-being of its inhabitants, not the gross domestic product or the how much money somebody makes. And so to me, it's sometimes really just embarrassing and shameful that we aren't sharing resources enough. And I'm always so inspired by Dr. Firo and others on this call. So thank you.
Thank you very much, Dr. Lugazi, and everyone else, Dr. Tesfaye, for the nice presentation of the current data or available data, because that's not all. This is what you have. It's probably a lot more than this. So we had a recent discussion about this. I think Dr. Mamba was on the conference. We're trying to partner with CDC in America, and we're going to do data collection on poisoning in Ethiopia. So I think Dr. Mamba will highlight the details and the plan in the near future, and everybody can participate. We can go region by region. People in Harar can do the same, in Bahar Dar, in Awasa, in Addis Ababa. This individual data can be combined together to highlight first regional differences, two, who's being affected, the younger ones, the teenagers, the older ones, and what is it that affects these people. So this will give us a data, what is going on in the country, and then we can ask for other help from other people like CDC, poison control, everywhere else. But they need something to see. These are all anecdotal events that we tell them. It should be combined, and that can be done. We all can participate. I volunteer to work with you all, and then we'll make it happen. And thank you for everybody's effort, enthusiasm, and hard work.
Can I second that? Can you guys hear me?
Sure.
So Dr. Geta is right. There's a lot of data there. So Dr. Mambao and Dr. Ayalo, who is also on this forum, who work with us on other projects, Dr. Tesfaye, everybody can participate in a big project, and we will actually like to help with the data analysis and even writing, projects and grants. So I just want to say, Dr. Daniel, thank you so much, and everyone who participated. I'm in New York. Dr. Zion and Getao are in New York. So sometime very soon we'll get together for maybe a dinner and we'll talk about this. But honestly, there is a lot to do and a lot of resources, and we should all work together. Eventually, as Daniel said, it's all our responsibility no matter where we live. And, we have the resources, we have the knowledge. It's just about application of what we know and what we can do. So if you're willing, Daniel, Dr. Dr.
Absolutely. I would love that. Yeah.
Okay, so we'll get together and maybe
Yep.
come up with a plan, and then we'll include the Ethiopian cohort. I might be going back very soon, as would probably Dr. Geto and Dr. Sion. We'll come up with a plan, and we can include all of our
Wonderful.
Ethiopian, compatriots. And thank you so much.
Thank you so
You're
much.
welcome. Thank you.
Indeed, actually, everyone, especially Dr. Zion, Professor Getao, and the rest of teams from USA. Thank you so much. Really, it was fantastic and historical event that we shared our knowledge, and it's really a good move. And we are on behalf of an emergency association, I would like to extend my appreciation and thank to all of the presenter. So please be in touch, and thank you so much, everyone.
Thank you and have a
Thank
nice
you,
day.
everybody.
Bye-bye.
See you.
Bye, everyone.